Good morning. I am Gordon Smith, the state's director of opioid response in the office of Governor Janet Mills, and it's my pleasure to welcome all of you to the 2022 Maine Maternal and Child Health and Substance Exposed Infants Conference. This year's conference, we will be highlighting the best practices and initiatives supporting the health of infants, children, pregnant persons, and parenting families. The theme, as you know, is building preventive, collaborative, and compassionate partnerships. We'll be together for 2 days from today from 8:30 to 4:30 and 8:30 to 4:30 tomorrow on Thursday. Dr. Nirav Shah will give the opening tomorrow morning. I'm glad I'm not following Dr. Shah, which is difficult to do. I really appreciate the chance to open the conference this morning. It's been my privilege to do that the last 3 years. I remember distinctly in 2019, we were up at Jeff's Catering in Brewer, and there was 150 to 200 people. And I was blown away on that day of all the activities around these subjects and all the good work that was being done in Maine. Conference was virtual in 2000 and 2001, and a decision was made to keep it virtual because so many of you are able to participate without having to drive, and we're also able to welcome people from other states. So while the vast majority of you watching are from Maine, there are also participants in 12 other states, I'm told. We have over 500 registrations, and really excited about the content. I want to thank Dara Fruchter and her terrific team at the Maine Center for Disease Control and Prevention. And as some of you know, we're losing Dara from the office, I think like the end of this week, but she's coming over to the Department of Education, where she'll be actually working at the cross office building 1 floor above me, as I recall, and once we all get back to the office. And so, Dara, you've done a terrific job on these conferences, and thank you, and I know your colleagues will miss you there. I also want to thank our sponsor, the New England Prevention Technology Transfer Center, which is funded by SAMHSA, and I want to thank them for sponsoring the conference. The PTTC, as we affectionately call it, provides training, technical assistance to the professionals, healthcare professionals, coalitions, volunteers to help translate prevention science into impactful and evidence-based prevention services in states and communities in the New England region. The PTTC is administered and housed right here in Augusta, Maine, at AdCare Educational Institute of Maine, Inc. And the New England PTTC provides a variety of training, technical assistance services, including webinars, self-paced courses, in-person trainings, and resource development. And they can also provide customized services to individual states and communities based upon their needs. And all the services are free. Let me repeat that. All these services by the PTTC are free. And to learn more, you can visit their website at pttcnetwork.org/New England. That's pttcnetwork.org/New England. Before making some comments about our situation currently with substance use disorder in Maine, I want to take a moment to thank all of you for your work. Many of you, the vast majority of you, provide services to this very special population of moms and substance-affected infants and youth. Unfortunately, we continue in Maine to see substance use at earlier ages than previously. We've always known that substance use disorders are rooted in adverse childhood events and trauma, and that many of our prevention initiatives are aimed at about middle school ages, but we believe now that we need to be providing solid social emotional learning and coping skills to even younger youth. We just were able to come up with an additional $1 million that's been put into a current RFP that's out for local prevention partners to create relationships with seventh graders in our public health districts to deliver some of the education that's available. The tragic overdose a few months ago of a 14-year-old girl who was using with a 12-year-old girl was a really gut-wrenching punch to all of us. We had not previously lost an individual under the age of 17. And the story in the Bangor Daily News this morning about a case that's in court today of involving an 11-month-old infant who got into parents' stash of fentanyl and nearly died. That infant is now 2 years old and is doing well, but was intubated in near death at the time of the incident. And her father's being charged with several felonies that are going to court today. So again, I want to thank you for your work and for your taking the time to join us today. And we have, for this really fantastic array of speakers over the 2 days, I want to comment specifically on our Voices of Recovery. There's 3 filmed Voices of Recovery who are all moms, Sarah, Jamie, and Angela. Sarah, we know well. She had opened for Governor Mills at our summit in Bangor on July 13th. And Sarah actually opened virtually for the governor last year in our virtual summit. And I've seen all 3 of these videos, and they're very poignant. They address very significantly the issues of shame and stigma. And we're so appreciative of those 3 individuals preparing their remarks for the conference. I know the conference closes too with a mom and daughter presentation from Sherry and Emily. And I'm sure that will be equally poignant and valuable. I can tell you from the governor's 4 summits that while you will quickly forget anything that I've said this morning, you will remember these presentations from these amazing moms for a long time to come. I want to comment on where the issue of child health, substance affected infants and moms fit into the governor's strategic plan. We've had a strategic plan that was updated about 18 months ago and is being updated again. And we constantly review the plan that's always been based around the 5 pillars of prevention, treatment, harm reduction, and recovery support. Recovery support being recovery centers, recovery coaches, recovery campuses, recovery-friendly work sites, recovery residences. People in both short-term, the early stages of recovery particularly need a lot of support. And then the 5th pillar is really leadership. It's the work that the governor and I are out there doing every day to address this issue. On October 7th, at our monthly webinar that we have the first Friday of each month, 11:30 to 12:30, no cost to participants unless you're getting CME, continuing education credits, and then the cost is $25. But each month we have a webinar that attracts 200 to 400 people. And on October 7th, we're dedicating that session to simply reviewing the strategic plan and asking people to provide input into the plan and looking at what changes that there may be necessary. It's constantly, the drug supply is constantly changing, the circumstances, the context is constantly changing, and we need to be continuing to evaluate where the priorities should be. should they be in harm reduction, because we continue to see a high number of overdoses. We've had a very rough year. On the other hand, 9,000 people, approximately Mainers this year, will survive an overdose. So we have our options program and other initiatives to address connecting these individuals with either harm reduction or recovery services, treatment services, so that they don't end, so that that individual does not end up on the other ledger. I'm going to conclude by just sharing with you some of the provisions of the existing plan that directly relate to child health, substance-affected infants, and moms. So under the prevention strategies, priority B is preventing early use. We know that the longer we can delay an adolescent from beginning to go down this path, whether it's alcohol, marijuana, or harder drugs, the longer we can delay that start, the more likely that it may not occur at all, or if it occurs, that it will end up with a better result. We also have strategy number 6, which supports healthy early childhood development, and there's 11 activities under that strategy. There are 10 priorities in the strategic plan, and there are 33 different strategies. Number 7 under prevention is to reduce adverse childhood experiences. Number 8 is to promote life skills and resilience building for all youth. And I know part of this conference you're dealing with Youth Matters and resilience and the work of the Maine Resilience Building Network, which does terrific work. Number 9 strategy is identify and support youth and young adults at risk of developing a substance use disorder. So we put a lot of money into SPIRT screening and brief interventions and referral to treatment. And ideally, we hope to have every individual at various points screened for substance use disorders. Under harm reduction, we have naloxone distribution now postpartum to postpartum patients that we support. We have support with supporting quality improvement initiatives for pregnant women. We have, of course, the Maine Mom program. We had Eat, Sleep, Console, the Plan of Safe Care, Snuggle Me. There's a tremendous amount of work going on within the 4 offices of the Child and Family Services, the Office of Behavioral Health, the CDC-P, and Maine Care. And it's part of my responsibility to make sure that those activities, as good as they are done in coordination with one another. So again, under treatment, obviously too, there are several strategies that deal with the subject, including strategy 21, which is to dedicate staff and funding to support the screening, treatment, and recovery of pregnant women with substance use disorder and support substance-exposed infants. So there are a number of initiatives, the 6 existing activities in that under that strategy and 6 future activities. So I encourage you to provide us input. Many of you will be sent a questionnaire that allows you to give us some thoughts in a SurveyMonkey instrument, and then we'll be doing the webinar on October 7th. We also will reach out to some special populations, including people who are using drugs, and then present some recommendations to the governor in November, take those recommendations out to the public, and hope to have an updated strategic plan by the end of December. So my time is up. I can't tell you how much I appreciate you all attending. I'm going to go get off the panel, go on to the conference site so that I can, like you, learn from as many of these presentations as I can watch the next 2 days. So thank you, Dara, again, and thank all of you. And now I think I'm leaving you with the incomparable Dr. Amy Belisle, our child health officer for the state, and one of the many physicians that I have access to daily, about 7 the last time I looked, within the various HHS offices, and they're not just, they're excellent physicians and really support a lot of our activities. So Amy, I'm handing it off to you. And again, have a great conference. And thanks everyone for attending.
Good morning, and thank you very much, Gordon, for that great introduction to the conference. And my name is Amy Belisle. I'm the Chief Child Health Officer at Maine DHHS, and I want to thank you all very much for joining us today for the 2022 Maternal and Child Health and Substance Exposed Infants Conference. On behalf of the Department of Health and Human Services Commissioner, Dr. Jean Lambrou, I want to welcome you all to this event and thank you to all of our wonderful speakers who are joining us over the next 2 days. This morning, you'll hear a lot about the work happening in the different state offices to support maternal and child health. And as Gordon noted, we have some wonderful recovery stories that we'll be highlighting at this conference. And they are really the most powerful voices for change that we can share with you over the next 2 days. We'll also be celebrating over the next 2 days work happening in Maine communities and showcase some of the new programs happening in the state, including Help Me Grow, which have been developed despite the challenging times of the COVID-19 pandemic. Before we get started, I want to thank all of you for the work that you have done to improve the health of women, children, families, and caregivers in your communities. With this conference, we will hear a lot about statewide programs and building systems to improve care. But we recognize that a lot of the work happens in the state at the community level. In IT terms, when laying the internet cables, they talk about the last mile being the most challenging. In a rural state like Maine, it can be the last 25 miles that are the most challenging and rewarding in public health, as you are translating all the systems and policy work into programs at the community level. Yesterday, I was able to join one of the many community COVID-19 vaccine clinics at the Children's Museum of Maine. It was amazing because it was a large community effort targeted to provide vaccines to young children, but they ended up providing vaccines to lots of youth and older adults who needed the new bivalent booster. It reminded me again that those of you who work in maternal and child health are serving not only our youngest children, but the whole family, including parents, caregivers, older youth, and grandparents, in order to keep our communities healthy and safe. We are grateful to all of the continued work that you're doing around COVID-19 to provide testing, medications, updated boosters, and vaccines for children under the age of 5. Before we get started with today's first speaker, I wanted to set the stage by highlighting some of the work happening at the state around perinatal health, as we closely track the infant mortality rate in the state, as it is a sentinel marker for the state of women and children's health in Maine. Maine is working to achieve the best possible maternal and birth outcomes and ensure that all mothers, birthing people, and infants receive timely and high quality care. Despite medical advances over the last 40 years, maternal and infant mortality rates remain high in many parts of the United States, with striking racial, ethnic, and geographic disparities. And Maine has had one of the higher infant mortality rates compared to other New England states in the last 10 years. In order to improve the infant mortality rate in Maine, in August of 2019, the Maine Department of Health and Human Services and the Maine CDC asked all the birthing hospitals in the state to participate in a life-saving initiative to reduce unsafe sleep deaths by achieving at least the bronze level certification of safe sleep through the National Cribs for Kids organization. And all the hospitals did this by April of 2021. Maine DHHS has also led the Strengthening the Perinatal Systems of Care Working Group with public and private partners since January of 2020, and worked with all hospitals to review and provide guidance on the standard approach to perinatal and newborn levels of care in the hospitals. The state has also worked to ensure healthcare coverage of pregnant people. And in addition to Medicaid expansion in 2019, this summer, Governor Mills announced the extension of MaineCare healthcare coverage for new mothers from 60 days after a woman gives birth to 12 months postpartum beginning in August. DHHS has also championed healthcare quality improvement efforts with the Maine Perinatal Quality Collaborative and has become an AIM state, which is the Alliance for Innovation on Maternal Health, and is doing work with the birth hospitals on evidence-based patient safety bundles. We're also trying to align this work at DHHS with the federal initiatives focused on maternal health, including the comprehensive maternity care action plan introduced by CMS this summer. In 2021, the state has seen a reduction in infant deaths due to unsafe sleep conditions, and the infant mortality rate has improved to 5.2 infant deaths per 1,000 live births. And although we are making progress in the state improving the infant mortality rate, there is still a lot of work to be done. We are closely monitoring the maternal mortality rates and working on state policy and programs to ensure access to high quality perinatal care for pregnant people and babies. And the state and its partners are fortunate to have received 4 new federal funding opportunities to support perinatal health this fall. This funding will provide over $10 million new dollars to the state over the next 5 years to build infrastructure around perinatal health with medical providers, support new programs to increase access to maternity care for rural communities and diverse populations, and will help build a strong, healthy foundation for the next generation of Mainers. In order to continue to move this work forward, it's important to learn from other states and national programs about how they are addressing maternal and child health issues. I'm delighted to introduce today's morning keynote speaker, Dr. Kathryn Baca, who will address maternal and child health and substance use both nationally and in Connecticut. She's an experienced maternal and child health epidemiologist and is the CDC's Maternal and Child Health Epidemiology State Assignee and a lead maternal and child health epidemiologist at the Connecticut Department of Public Health. She contributes to epidemiologic surveillance for maternal and newborn health, including neonatal data capacity through data linkages. And Dr. Baca also supports programs and work groups to include both equity inclusion and community-driven research. She provides technical assistance to various statewide work groups, including those on parenting and pregnant people with substance use disorder and substance-exposed infants. And additionally, she is a leader of one of the leaders of the Connecticut Reproductive Justice Alliance, which aims to improve respectful and quality maternity care in Connecticut. So we really appreciate you joining us, Dr. Baca, and we look forward to your talk.
Thank you. Are we ready for the presentation? All right, great. Thank you so much for the introduction and also for the overview that you've provided on maternal and child health in Maine. I'm just going to share my screen. Can you see the screen?
Yes, you're all set.
Great, thank you so much. So hello, everyone. And thank you first for the opportunity to present on maternal and child health and substance use nationally and Connecticut. I am excited to share national data and CDC initiatives around substance-exposed infants. And I'll also be highlighting some important work that is being done in Connecticut due to my role as a CDC state assignee to Connecticut Department of Public Health. Through this position, I've been able to be part of the collaborative work around substance-exposed infants in Connecticut, and I hope to share, I'm going to share some of that in today's presentation. And one theme that I'll be noting throughout the presentation is the importance of collaboration. So this first half of the presentation will have a focus on national data and then the CDC initiatives in maternal and child health. The National Center for Health Statistics has released mortality data for the nation in 2021, which included data on overdose deaths, and the age-adjusted rate of drug overdose deaths increased by 31% from 2019 to 2020. And I'm looking at the black line here in this figure. Among adults aged 35 to 44, which is the age group with the highest rates, drug overdose deaths increased by 33% from 2019 to 2020. And the rate of drug overdose deaths involving synthetic opioids other than methadone, such as fentanyl, increased by 56%. From 11.4 in 2019 to 17.8 in 2020. I also want to point out that rates increased from 2019 to 2020 for all race and Hispanic origin groups. In both 2019 and 2020, rates were highest for non-Hispanic American Indian or Alaska Native group people, and lowest for non-Hispanic Asian people. Among all race and Hispanic origin groups, the largest percentage increases in drug overdose deaths from 2019 to 2020 were seen in non-Hispanic Black and non-Hispanic Native Hawaiian or other Pacific Islander people. Studies from 2018 to 2020 have found some concerning trends in opioid use during pregnancy, and specifically opioid use disorder among pregnant persons. A cross-sectional study using 1996 to 2014 treatment episode data set emissions, national data from pregnant admissions with opioid use disorder or OUD, determined that the proportion of pregnant persons with OUD admitted to treatment for substance use disorder or SUD increased from 17% to 42% between the time period. Additionally, a cross-sectional analysis of 2010 to 2017 healthcare cost and utilization projects, national inpatient sample and state inpatient databases, which is an all-payer compendium of hospital discharge records from community non-rehabilitation hospitals in 47 states and DC, determined a 131% increase in opioid-related diagnosis at childbirth from 2010 to 2017. And most recently, CDC analyzed 2019 data from the Pregnancy Risk Assessment Monitoring System, or PRAM survey data from 34 jurisdictions, and found that 6.6% of respondents indicated opioid use during pregnancy. And among these individuals, 21.2% indicated misuse, and 27.1% reported wanting or needing to reduce or stop using opioids during pregnancy. So why are we interested in measuring opioid use during pregnancy? We know that from several studies that opioid use during pregnancy has been associated with infant and maternal outcomes, including preterm labor, neonatal abstinence syndrome or neonatal opioid withdrawal syndrome, intrauterine growth restriction and stillbirth among infants, and depression, anxiety, and chronic medical conditions among birthing persons. And unfortunately, we are seeing overdoses during and after pregnancy as well. There are multiple CDC-led initiatives with an overarching goal of reducing maternal mortality, which include overdose deaths. CDC has made 30 awards supporting 31 states for the Enhancing Reviews and Surveillance to Eliminate Maternal Mortality, or ERASE program. And this funding directly supports agencies and organizations that coordinate and manage maternal mortality review committees to identify, review, and characterize maternal deaths and identify prevention opportunities. And this work will facilitate an understanding of the drivers of maternal mortality and complications of pregnancy, and better understand the associated disparities. Determine what interventions at patient, provider, facility, system, and community levels will have the most effect, and inform the implementation of initiatives in the right places for families and communities who need them most. Maternal mortality review committees, or MMRCs, are multidisciplinary collaborative committees in states and cities that perform comprehensive reviews of deaths among persons within a year of the end of a pregnancy. They include representatives from public health, obstetrics and gynecology, maternal fetal medicine, nursing, midwifery, forensic pathology, mental and behavioral health, patient advocacy groups, and community-based organizations. And some of these committees are also inviting people from communities. CDC works in collaboration with MMRCs to improve review processes that inform recommendations for preventing future deaths. MARIA, or Maternal Mortality Review Information Application, is a data system and data strategy designed to facilitate MMRC functions through a common data language. CDC, in partnership with users from the committees and other subject matter experts, developed the system It is available to all MMRCs, and Review to Action is a website for promoting best practices in maternal mortality review, and it assists jurisdictions without an MMRC in gathering resources, tools, and provides support for establishing a review committee. In addition, it connects jurisdictions with an established MMRC to best practices, resources and support, and raises awareness of the critical role MMRCs play in eliminating preventable maternal deaths. Now to focus on the Rapid Maternal Overdose Review, or RMOR. This initiative supported 6 states, including Massachusetts, Utah, Ohio, Wisconsin, Tennessee, and North Carolina, in reviewing all pregnancy-associated overdose deaths in their states. Through RMOR, CDC is developing processes and tools for committees to use to improve data quality and collection to better capture overdose deaths. And the initiative is also making sure that the right people are on the committee to review an overdose death, such as a mental health or addiction specialist. And the data from this collaborative effort is being used to develop recommendations for prevention. In the next couple slides, I'll be going through the highlights of the results of this review from these 6 states, which illustrates missed opportunities of preventing overdose deaths. Again, these reviews for deaths that occurred from 2015 to 2019. In total, there were 104 pregnancy-associated overdose deaths in these 6 states, and the individual characteristics of the 104 pregnancy-associated overdose deaths include more deaths occurring in non-Hispanic white individuals. You can see that 80% were non-Hispanic white. We can also see that most deaths occurred for individuals who were 25 to 34 years old. And also of interest was the high number of individuals that had Medicaid during pregnancy or at delivery. And also, I just want to note that most, or 73% of pregnancy-associated overdose deaths occurred in the late postpartum period, or 43 to 365 days after pregnancy. And the most common observed substance class was opioids, with 81 of the deaths indicating presence of an opioid. And within those deaths, an opioid was present. Fentanyl was found in the toxicology results of 58, which is more than half of the overdose deaths. So some more key findings of this review, 89% of the 104 pregnant or postpartum people had a history of substance use in their records, as you can see in the first pie chart. If you look at the second pie chart, among these 93 individuals, 47% or 44 individuals had history of substance use treatment. And most of these 44 individuals received treatment before pregnancy, and treatment decreased after pregnancy. More specifically, the proportions of individuals receiving substance use treatment during pregnancy was 64%, and after was 45%, which was low compared to the proportion who had substance use treatment prior to pregnancy, which was 89%. Furthermore, only 50% of the 104 individuals with pregnancy-associated overdose deaths had substance use documented in the prenatal records. Again, that is 50% of the 104 individuals. There were several factors captured in the qualitative analysis that could contribute to the missed opportunities for screening and for getting individuals into treatment for substance use disorder. Some individuals in the analysis had missed or incomplete prenatal care, narrowing the window for screening. And it was also more common to see substance use screenings in emergency room records in the RMOR data, which are often not shared with primary prenatal labor and delivery or postpartum care providers. And a few more findings, 72% of the 104 pregnant or postpartum people had evidence of mental health conditions in their records. And among these 75 people, 59 or 79% had a history of mental health treatment. While a large portion of individuals, or 93%, received treatment prior to pregnancy, it is important to note this could have been at any time before pregnancy, and a larger portion of time is covered. 75 individuals had evidence of mental health conditions, but only 33 individuals received treatment during pregnancy, or 56%, and 35 individuals received treatment after pregnancy, or 59%. Please note that these groupings are not mutually exclusive, and one person may have received treatment prior to pregnancy, during pregnancy, as well as during the postpartum period. An important part of understanding what was captured in this study came from the qualitative analysis of case narratives in the committee decision form. And this process allowed researchers to provide more context for the quantitative data captured in Maryann. And to give more context, there are 6 key decisions that maternal mortality review committees make for each death that is reviewed. And these questions are: was the death pregnancy related? What was the cause of death? Was the death preventable? What were the critical contributing factors to the death? What are the recommendations and actions that address these contributing factors? And lastly, what is the anticipated impact of those actions if implemented? In the study, multiple stresses were found around housing instability, including homelessness, violence, sometimes across their lifespan, which included intimate partner violence, childhood trauma, personal and familial, physical and sexual abuse and rape. Individuals also experienced incarceration prior to, during, and after the sentinel pregnancy, sometimes disrupting the appropriate substance use and prenatal care. Also, financial instability and unemployment. And lastly, there was a theme around loss of child. And this theme included death or loss of a child or children to stillbirth, induced or spontaneous loss of pregnancy, and the removal of children by Child Protective Services, or loss of a child to custody issues. This collaborative work involving 6 states, CDC, and MMRC members were able to conclude the following: substance use disorder and other mental health conditions were the most common MMRC identified circumstances contributing to pregnancy-associated overdose deaths. In addition, there is a need to remove barriers to treatment for individuals who are pregnant and beyond the first 42 days of the postpartum period. And as highlighted in the Maryann data, qualitative analysis of case narratives in the committee decision form, there were missed opportunities for screening, referral, and treatment, in addition to access to appropriate substance use and mental health care, and treatment and continuity of care needs to be addressed to prevent future pregnancy-associated overdose deaths. As we all know, opioid use also impacts infant health. I want to note that opioid withdrawal syndrome in the newborn has traditionally been called neonatal abstinence syndrome, or NAS. However, more recently, it has been called neonatal opioid withdrawal syndrome, or NOWS, by federal agencies, as well as state agencies. While NAS is more a general term for neonatal withdrawal, that in the literature may include non-opioid exposures. Evidence suggests that the recent growths of neonatal drug withdrawal has been primarily from in utero opioid exposure, either in isolation or in combination with other substances. NOWS is a drug withdrawal syndrome in newborns who have been exposed to opioid substances in the womb prior to birth. And this exposure can be from prescription pain medications such as Vicodin, Oxycontin, Percocet, from illicit substances such as heroin, or from opioid maintenance therapies such as methadone or buprenorphine. Signs of NOWS are evident within 48 to 72 hours after birth and include tremors and seizures, excessive crying, poor feeding, vomiting, loose stools, and temperature instability. This slide shows results from a recent cross-sectional study of 2010 to 2017 data, both NES, which is represented by the blue line on the figure, and maternal opioid related diagnosis, or MOD, which is the orange line, increased substantially during this time period. The national estimated rate of NES was 7.3 per 1,000 birth hospitalizations, and the rate of MOD was 8.2 per 1,000 delivery hospitalizations in 2017. There were larger increases in MOD rates than in NAS rates with the transition to ICD-10, which included additional codes for long-term and unspecified opioid use. Definitional differences notwithstanding, this indicates continued increases in both NAS and MOD since the year 2000. The analysis also found notable state-level variation. The top two maps illustrate the rate of NAS and the percent change in NAS from 2010 to 2017 by state. And the bottom two maps illustrate the rate of MOD and the percent change in MOD from 2010 to 2017 by state. Please note that for both NAS and MOD rates are higher in Maine in 2017 than most other states in the nation. However, the rate change was minimal compared to other states. According to 2016 estimates, the overall incidence rate of NAS was 6.7 per 1,000 in hospital births. It is important to note that rates were highest among American Indians, Alaska Natives at 15.9 per 1,000, people in lowest income quartile or 9.3 per 1,000, and people living in rural areas at 10.6 per 1,000. Another study published in 2020 found that racial and ethnic disparities in the use of medications to treat opioid use disorder, or OUD, during pregnancy amongst women with OUD who delivered a live infant. Black and Hispanic women with OUD were significantly less likely to use any medication for treatment and were less likely to consistently use medication for treatment during pregnancy compared with white women with OUD. Compared to 69.9% of white non-Hispanic women, 49.4% of Hispanic and 46.2% of Black non-Hispanic women with OUD used medication for treatment. The authors hypothesized that factors associated with avoiding the use of medication to treat OUD could include a person's desire to minimize medication exposures to the fetus and avoid the risk of neonatal withdrawal, shame and stigma because of their drug use, and fear of being reported to Child Protective Services. We know that the opioid epidemic has affected mostly white families, but it is important to note that the problem of substance use and mental health has plagued minority communities for years. We are learning that perhaps a kinder, gentler approach is a more effective approach as compared to the approach taken during the crack cocaine epidemic of the 90s. At that time, stigma weighed heavily on mothers, but now we understand the need is to not stigmatize. In addition, American Academy of Pediatrics also decided to revise its guidance with a lens to the mother-infant dyad. And I'll talk more about this updated guidance in a later slide. It is important to deliver evidence-based standardized care that takes these factors into account to ensure equity. So far, I've been mostly focused on opioid use, but I also want to highlight some work that is focused on cannabis use during pregnancy. There has been some multi-state analyses using PRAM's marijuana supplement to determine marijuana use during pregnancy and at postpartum. The studies determined that 4.2% reported marijuana use during pregnancy, while 5.5% reported marijuana use at postpartum. Of these people who reported marijuana use at postpartum, 47.2% were breastfeeding at the time of the survey. Additionally, 25.7% reported that they were advised against marijuana use while breastfeeding. This data can be used to help determine points of improvement, like consistent advice on marijuana use during and at pregnancy, as well as postpartum. So CDC is committed to improving infant health, and this requires public health agencies working together with healthcare providers, communities, and partners. This joint approach can help address the social, behavioral, and health risk factors that affect birth outcomes and contribute to infant mortality. We collect data on emerging topics through PRAMS, which I presented a little bit already, or the Pregnancy Risk Assessment Monitoring System. PRAMS collects state-specific population-based data on maternal attitudes and experiences before, during, and shortly after pregnancy. PRAMS data can be used to identify groups of women and infants at high risk for health problems and to measure progress toward goals in improving the health of mothers and infants. We are also working to improve our understanding of sudden and unexpected infant death. CDC's Division of Reproductive Health has SUID monitoring programs in 22 states and jurisdictions, covering about 1 in 3 SUID cases in the United States. Participating states and jurisdictions use data about SUID trends and circumstances to develop strategies to reduce future deaths. The SUID and Sudden Death in the Young Case Registry brings together information about the circumstances associated with SUID and SDY cases, as well as information about investigations into these deaths. We currently use all of this data to inform the efforts of the Perinatal Quality Collaborative, or PQCs, to support quality standardized care for women and children. PQCs are state or multi-state networks of teams working to improve health outcomes for mothers and babies. Funding supports the capabilities of PQCs to improve the quality of perinatal care in their states, including efforts to reduce preterm birth, improve prematurity outcomes. CDC works with experts to develop resources PQCs can use to further their development. CDC and the March of Dimes also launched the National Network of Perinatal Quality Collaboratives, or NNPQC, which expands the reach of lessons learned on a national scale. The National Institute for Children's Health Quality currently serves as the coordinating center for the NNPQC. Another tool that we have for improving access to quality care is CDC Locate. Locate helps states and other jurisdictions assess the systems of risk-appropriate care in their regions, enabling them to show the capabilities of staffing services within levels of maternal and neonatal care among delivery facilities. Locate is building better systems to improve how we care for mothers and infants. And finally, we built support to improve maternal and child health. The Maternal and Child Health Epidemiology Program assigns epidemiologists and fellows to states, localities, and tribes to support epidemiologic research and provide scientific information to improve maternal and child health programs and policies. Through this program, and in partnership with AMCHIP, we developed the State Infant Mortality, or SIM toolkit, to help states, counties, tribes, and urban areas analyze infant mortality data and translate findings into programs and policies to reduce infant mortality. I like to now share an example of how PQCs have worked to improve outcomes using a comprehensive care approach to treating infants with NOWs is important to improving outcomes of these infants. More specifically, the Eat, Sleep, Console model, which was developed in 2014 and is family-centered, non-pharmacologic approach to treat NOWs by promoting maternal engagement, breastfeeding, and mother and baby rooming in, and by conducting function-based assessments of infants with NOWs. The Perinatal Neonatal Quality Improvement Network of Massachusetts has implemented this care tool to improve outcomes of infants with NOWS. And this tool evaluates the infant based on their ability to eat, sleep, and be consoled. The PNQIN instituted a formal QI initiative in 2017 to implement the care tool in centers pursuing the ESC statewide QI study, where 11 hospitals adopted the care tool. The QI initiative determined that since the care tool implementation, there has been a decrease in pharmacotherapy and length of stay without an increase in short-term adverse events. And these hospitals also reported making changes in prenatal education, rooming in, breastfeeding, and non-pharmacologic care bundles. The study concluded that the ESC care tool approach, by involving the caregiver as a key component of the assessment and inclusion of the NPI checklist at every assessment, and inherently triggers culture change focused on maternal-infant bonding and patient-centered approach. DRH is also working to address emerging issues in infant health, including improving the quality of care of infants exposed to opioids. DRH is currently collaborating with the American Academy of Pediatrics on the Maternal Infant Health and Opioid Use Project, which aims to improve the quality of care of infants exposed to opioids prenatally or diagnosed with NOWS, and of pregnant or parenting people with opioid use disorder. The project develops and promotes educational tools and resources that support the patient and the family-centered care of NET framework, including linkages to services for infants with prenatal opioid exposure and linkages to care and treatment for women of reproductive age with opioid use disorder, as well as addressing negative social attitudes and stigma towards pregnant and parenting people or parenting women. AAP has developed educational offerings for hospital-based and community-based providers. One example is the Plans of Safe Care for Infants Exposed to Opioids course. This course targets hospital-based pediatric teams and focuses on approaches to caring for pregnant and parenting women with opioid use disorder and infants exposed to opioids prenatally. Another is the Maternal Infant Health and Opioid Use ECHO project, which aims to educate and train pediatric primary care practices in implementing clinical interventions with respect to screening, referring to treatment, providing women of reproductive age with OUD through recovery. That project incorporates quality improvement work and uses the family-centered framework that is core to the pediatric medical home to focus on both systems of services for infants exposed to opioids prenatally, as well as linkages to care for pregnant women and mothers with OUD. This is one of many partnerships to improve care for mothers and infants. As many of you know, in November 2020, a new AAP clinical report was published to serve as a companion to the 2012 report. The new report gives pediatric providers more information and tools to improve the care of infants born with NOWS. The report describes the clinical presentation of NOWS, noting timing and onset, and how opioid exposure can originate from prescription pain medications, illicit substances, or medications for opioid use disorder. Assessment of NOWS is discussed with consideration of maternal and neonatal screening and testing, and old and new neonatal scoring systems, including the challenges of objectivity and inter-rater reliability. The report also provides a broader approach to treatment based on new evidence, including non-pharmacologic and pharmacologics. And it discusses considerations for discharge, such as incorporating a transition to home process that considers the mother-infant diet and longer-term follow-up and support. So here is where I transition to the collaborative work that is being done in Connecticut. But before I do, I want to just take a pause and provide a few facts of Connecticut before moving on to the next slide. So for this presentation, I asked my colleagues for their favorite Connecticut-related facts, and they collectively said that Connecticut is home to the best pizza in the nation. Connecticut is also home to the first hamburger. Might not be the best. I think they boil the hamburger or something. And the oldest, Connecticut has the oldest continuously published newspaper in the US, and it's called the Hartford Courant. And World Wrestling Entertainment, or WWE, headquarters is located in Connecticut. And lastly, Kathryn Hepburn grew up in Hartford, Connecticut. And some more serious facts that are related to the presentation. Connecticut has 169 towns, 21 cities, and 8 counties, although its counties do not have a government structure. There are about 32 to 35,000 births in Connecticut each year, so it's a fairly small state. And like many other states, the state is experiencing closures of labor and delivery units at hospitals. I think since 2010, there have been 3 official closures, and also 3 additional labor and delivery units have suspended their services, and they're applied to close. So therefore, it is important to work with communities to better understand the barriers to access to care. And I think it's also important to point out that Connecticut has some of the highest levels of income inequality in the nation. Using the Census 2020 Gini Index, it is the 5th worst in the nation. So now let's take a closer look at how Connecticut is using collaboration and partnerships to improve the well-being of substance-exposed infants and parenting people with substance use. So collaboration and partnerships across the state of Connecticut aims to provide needed services and supports for infants with prenatal exposure, the birthing person with substance use disorders, and their families to ensure a comprehensive response. And this slide shows the partnerships that currently exist in Connecticut in this initiative. Includes Connecticut Department of Children and Families, Connecticut Department of Mental Health and Addiction Services, or DEMAS, Connecticut Department of Public Health, United Way, American Academy of Pediatrics, ACOG, Wheeler Clinic, Connecticut Hospital Association, and Child Advocate. In Connecticut, there is a collaborative initiative called Substance Exposed Pregnancy Initiative of Connecticut, or SEPI-CT. Originally, it was called Substance Exposed Infant Fetal Alcohol Spectrum Disorder, SEI-FASD. They just recently changed it to make it more easily pronounced, basically, and more specific to the work that is being done by this group. And this group aims to strengthen capacity at the community, provider, and system levels to improve the safety, health, and well-being of substance-exposed infants and support the recovery of pregnant and birthing people and their families. The initiative began in 2015, which is supported by the Connecticut Department of Mental Health and Addiction Services, or DEMAS, and Connecticut Department of Children and Families through Wheeler Clinic. So this is the structure of the work for SEPI-CT. There is the executive team, the SEPI-CT program, which consists of the SEPI-CT program manager, together with the DCF and DEMAS leadership. And this group meets bi-weekly to maintain consistent communication on the ongoing status of the initiative and provide guidance and support to the program manager as needed. And then there is the core team, which is a group of stakeholders or partners who provide leadership and direction for the project. These individuals and agency representatives have expertise in maternal and child health, behavioral health, substance use, child welfare, and advocacy for women and birthing people. This group meets quarterly to discuss updates in emerging work. And lastly, there are the work groups. The work groups support the deliverables of each respective priority area, and each work group meets about once a month. I am personally part of the core team and a part of one of the work groups. The new 5-year strategic plan for SEPI-CT, you can see that here it's has the old name FASD SEI. So this is an illustration of the new 5-year strategic plan, which has a commitment to prioritize equity and inclusivity and is committed to respect and support of the health of people across the LGBTQI+ spectrum. This initiative is cognizant that the topics addressed in the plan that fall under the umbrella of women's health are not exclusive to cisgender individuals and can impact people across all gender identities. And this strategic plan expands on work that has initiated in the last 5 years, while also addresses new emerging topics and meaningfully incorporate a proactive lens of data, cultural competence, and health equity. As part of the plan, the work will continue to be informed by and measured by data. Additionally, the plan highlights efforts to identify and collect data beyond the national and state indicators that are currently available publicly, particularly new data collected as part of this initiative. The initiative will also incorporate cultural competence into ongoing and future work. Cultural competence plays an important role in promoting and providing respectful, informed, and personalized care to individuals of various backgrounds. Finally, the initiative will continue to spread awareness on the health disparities and inequities that occur within subpopulations and subsequently identify ways to address them. And to see the visual, you can actually access the link on this slide. And the priority areas for the framework include Child Abuse Prevention and Treatment Act, or Capta, and plans of safe care. And the goal for this priority area is to promote broad understanding of Capta reporting requirements and the values of plans of safe care. I'll be talking more about Capta notifications and plans of safe care in the next few slides. Basically, in this priority area, we'll continue to build local and statewide system capacities to enhance Capta and plans of safe care implementation, education, technical assistance, including increasing community outreach efforts to educate birthing people on the plans of safe care and continued transparency around Capta reporting process. The second priority area is the screening and brief intervention goal. And in this goal, the goal is to improve screening for substance use disorders and to provide appropriate services through provider education and enhancement of statewide referral systems. This priority will aim to promote universal screening practices while thoughtfully addressing the current barriers that make this challenging to implement broadly. This includes inventory of the current screening landscape across the state, increasing the availability of practice-specific screening-related trainings for providers and targeted outreach and collaborations with provider systems that are interested in enhancing their screening, brief intervention, or referral practices. There's also the marketing and training initiative or priority. In this priority, the goal is to create and enhance opportunities for SEPI-CT professional development and promote statewide awareness and knowledge. This priority will promote broad understanding of the complexities of perinatal addiction, best practice information, including but not limited to resources on supportive strategies for birthing people, families, and children who are affected by SUD, and the role of stigma. And this includes monthly digital campaigns, which I'll be showing one of these in a later slide, ongoing broad outreach efforts, development of a SEPI-CT 101 training, and collaborations with other intersecting initiatives. And lastly, there is the Treatment, Recovery, and Wellness Support Initiative or priority. And the goal for this is to ensure birthing people, children, and families have access to SEPI-CT, SEI, FASD, and SUD treatment, recovery, and support services. Priority 4 will address individual and system level opportunities and barriers to SED, treatment, recovery, and support and services that affect birthing people, families, and children. The initiative will continue to collaborate on 2 general interventions. The work group dedicated to this priority will continue to compile available state resources for parents whose children are impacted by FASD or SEI. And in doing so, efforts will be made to consolidate the information and address any gaps that may exist. SEPI-C2 will also focus on the disproportionate impacts of SED and mental health on birthing people and the Black, Indigenous people of color or BIPOC and LGBTQI+ communities, including collection of information on their experiences accessing SED or SCI FASD services. So this is a screenshot of Connecticut's newborn notification portal, which is a site that you can access through the QR code or the link or the website you can see that on the slide. The Child Abuse Prevention Treatment Act, or Capta, was originally enacted in 1974 and reauthorized in 2010 to include a policy requiring states to implement a notification process to DCF when a baby is born who has been prenatally exposed to substances. The Comprehensive Addiction and Recovery Act, or CARA, was signed into federal law in 2016 with the aim to address the problem of opioid addiction in the United States and offered amendments to Capta. Changes to the federal legislation around the Child Abuse Prevention and Treatment Act, or Capta, and CARA have outlined new state mandates requiring data collection around the impact of substance-exposed infants and development of plans of safe care nationwide. In Connecticut, effective March 15th, 2019, hospitals are required to submit a notification to DCF at the time of birth event when an infant is believed to have been exposed and/or displays withdrawal symptoms. Currently, there is updated legislation pending that changes the name of Plans of Safe Care to Family Care Plan, but I'm just going to continue to call it Plans of Safe Care in this presentation. DCF, in collaboration with stakeholders, developed and implemented a notification process and portal for the purposes of giving birthing hospitals the ability to create a Capta notification for newborns identified as substance exposed as defined by the notification criteria, or to file online reports or DCF 136 of abuse or neglect. The birthing hospital must make the notification as soon as the birthing event as possible and before discharge. And the portal was carefully designed to ensure that families that do not need the intervention of CPS are able to follow their plans of safe care and utilize community-based supports can do so without CPS intervention. In addition to the stakeholder collaboration, the team met with several groups of birthing people in recovery to ensure that the portal's development took into consideration their perspective and lived experience. So Connecticut has also partnered with United Way, or 211, to create a Plans of Safe Care website where the plan can be developed electronically and saved on a smartphone, tablet, or other supported electronic device. United Way has promoted the e-plan of safe care by distributing print media to households throughout the state. The current website can be accessed through the QR code on this slide, but please note that the improvements are currently being made and will eventually be moved to a different website. It might be on the Wheeler website, I'm not 100% sure. The development of plans of safe care for an infant born substance exposed with withdrawal symptoms or FASD ensures the safety and well-being of the dyad. The plans of safe care addresses the health and treatment needs of the mother, infant, and significant others, such as partners or family members. Our cross-system collaborative approach to develop plans of safe care recognizes that infants have a wide range of needs, including the need to have a safe and stable caregiver. The Plans of Safe Care is an empowerment tool to support the caregiver in making decisions that they feel will best support a lifestyle of health and wellness for themselves and their family. Ideally, the development of the Plans of Safe Care occurs prior to birth, giving the caregiver time to process and understand the Capta notification process and to build a resource network prior to delivery. Additionally, the Plans of Safe Care can be universal precaution and a roadmap that can be helpful for anyone who is pregnant or preparing to be pregnant. Here is a snapshot of the Connecticut Capta dashboard created by DCF. The dashboard provides summary data of most common needs, the number of notification submissions over time, type of exposure, as well as distribution by race and ethnicity. This particular snapshot on this dashboard provides Capta data summary through June 2022. So you can see that there are, from like the top left in the light blue box, there are 6,542 total submissions that were made to the portal since the launch in March 2019. In the gray box at the top, you can see that there were a total of 4,428 plans of safe care that were completed. The state's plan of safe care completion rate remains steady at 68% of notifications, and most of the plans of safe care have been developed by the hospital reporter. In the orange box at the top, you can see that 47% of notifications were recommended for referral to the DCF care line. And also Capta noted, so the Capta notifications represent on average 6% of live births during this reporting period. So from March 2019 to June 2022. You can see on the longer figure on the left that safe sleep education and resources remain the most common single need identified for the mother and baby. In the middle figure with the orange line, you can see that there are an average of 164 notifications per month. And in the bottom figure, you can see that marijuana or cannabis is the most identified infant substance exposure, occurring in more than 3/4 of notifications. The right figure shows the distribution of notifications by race ethnicity. 43.8% of notifications for white non-Hispanic birthing people, and 21.1% of notifications are for Black non-Hispanic birthing people, and 20.5% of notifications are were for Hispanic birthing people. So the reason why Capta data is important is that it can be analyzed and combined with other information to get a deeper understanding of the changes and impacts. So zip code data is collected during a Capta notification and can be overlaid with other data sources, such as census population data, which allows DCF to geomap the rate of Capta notifications that become reports to Child Protective Services and the per capita rate of Capta notifications by town. Geomaps, also called heat maps, depict the relative frequency of an event. And these frequency data informs policymakers about the relative impact of substance exposure across communities, and quickly identifies areas that may benefit from additional resources to support affected infants and families. In this heat map, the pink indicates resident areas of lower frequency of Capta notification complete with a plan of safe care. So these are areas that may need more training and awareness in plans of safe care. DCF also has combined Capta and American Community Survey data to reveal differences between Capta notifications and the state's overall population. It appears in this figure that non-Hispanic, white, and Asian individuals may be underrepresented in Capta, while non-Hispanic, Black, and Hispanic individuals may be overrepresented. These differences in Capta notifications by race and ethnicity is concerning, since it may indicate that a Black or Hispanic person is more likely to be screened or tested for substance use versus a white person. This analysis can be repeated to show progress towards reducing these inequities and improvements in screening. Additionally, Capta substance exposure data helps identify trends and target public awareness campaign materials. This DCF analysis determined that 8 of 10 infants are exposed to marijuana within the Capta data with or without other substances. This exposure data can be used to improve public awareness campaign materials around marijuana or cannabis use during pregnancy. This slide lists Connecticut resources supporting families and children resources where individuals learn about Capta and develop a plan of safe care. I'm just going to expand on a few of these resources. The Women's Reach or Recovery Engagement Access Coaching and Healing Program provides statewide integration of 15 recovery navigators positioned throughout each of the 5 DMIS regions. The recovery navigators are women who are in position to use their own personal recovery journey to help others. These women use recovery coaching techniques and case management services to support women in their community. And services are prioritized for pregnant and parenting people with substance use or co-occurring disorders. And PROUD, or Parents Recovering from Opioid Use Disorders, is a new SAMHSA-funded program of the Connecticut Department of Mental Health and Addiction Services that aims to serve pregnant and postpartum women with substance use disorders, including opioid use disorder, in the greater Hartford and New Britain areas. PROUD teams will complete a family needs assessment with eligible women and their household members to create a plan to address individual and family needs around substance use, mental health treatment, and connections to medical providers, including prenatal care, employment, housing, and recovery support. And just briefly, I want to mention the last listed resource, which is Access Mental Health for Moms resource. And this is a new resource in Connecticut. The Access Mental Health for Moms program is designed to improve access to treatment for pregnant and postpartum individuals with mental health and/or substance use recovery needs. Every frontline healthcare provider treating pregnant and postpartum individuals up to 1 year post-delivery presenting with mental health and/or substance use concerns, regardless of insurance, will have real-time access to telephonic psychiatric consultation and resource and referral support for their patients. Key components of the Access Mental Health for Moms program include free real-time perinatal psychiatric consultation and case-based education to obstetric, pediatric, and adult primary care and psychiatric providers, resource and provider support to community-based mental health and substance use services, and training and toolkits for providers and their staff on evidence-based guidelines for mental health and substance use screening and treatment. So as mentioned before, CEPI-CT creates and releases monthly campaigns with the goal of promoting broad understanding of the complexities of perinatal addiction, best practice information, including but not limited to resources on supportive strategies for birthing people, families, and children who are affected by a SUD, and the role of stigma. These are snapshots of one of the monthly campaigns that was released by CEPI-CT during Pride Month with a focus on celebrating LGBTQI+ parents and families. The campaign provides resources on support becoming a parent, as well as support for pregnant and parenting people who are struggling to reduce or stop substance use. Not shown here, there's a great section in this campaign that provides examples of inclusive language and shares quotes from patients on the importance of providers using inclusive language. The purpose of these campaigns is to increase awareness of available resources. And since we are finding that sometimes the issue is not the lack of resources, but a lack of knowing the available resources, in the CEPI-CT website archives all the monthly campaigns which are available to anyone. You can access the June campaign in the link provided there. And I think if you just delete a few of the words, you'll be able to access all of the campaigns. So just moving on a little bit from CEPI-CT, I would like to share some information on Connecticut PRAMs, since this surveillance project collects information on maternal health experiences and behaviors before, during, and shortly after pregnancy from postpartum individuals. PRAMs can provide information to programs and professionals for more than 80 indicators by maternal race, ethnicity, that helps identify positive and negative outcomes and behaviors, as well as related disparities, and therefore has almost unlimited potential for supporting health equity efforts. Because we draw our sample from vital records, there are additional data fields that are provided from the birth record, including maternal race and ethnicity. To date, PRAMs has provided data to a wide variety of programs and initiatives, both within the Connecticut Department of Public Health and statewide, and it has also informed statewide needs assessments and health plans and initiatives, including the Title V MCH block grant needs assessment, seeking to achieve health equity by optimizing population health and eliminating disparities. Connecticut PRAMs has also created a new cannabis questionnaire supplement in response to new Connecticut legislation on cannabis. In June 2021, an act concerning responsible and equitable regulation of adult use cannabis legalized the possession and consumption of cannabis in Connecticut for individuals 21 years old or older, starting July 1st, 2021, and sales will become legal sometime this year, if not already. And the legislation includes the Department of Public Health's role in collecting, abstracting, and disseminating timely public health information on the impact of cannabis use. PRAMs was one of the 3 key data sources for cannabis surveillance identified by the Governor's Office's National Consultant on Cannabis Legalization. In response to the legislation, Connecticut PRAMs developed a survey supplement that included questions about marijuana use and the use of cannabidiol or CBD products before, during, and after pregnancy. How, so either smoked, dabbed, vaped, etc., and why women use marijuana during pregnancy, including to relieve nausea, relieve stress or anxiety, and there are other options in the supplement. And also asking about conversations around marijuana use or recommendations during prenatal care. So like asking if their provider talked to them about marijuana use during prenatal care, as well as asking about their personal perceptions of how long someone should wait after using marijuana before breastfeeding or pumping milk for their baby. And if they think the use of marijuana products during pregnancy could be harmful to a baby's health. This supplement is being implemented for the entire 2022 surveillance year, which began data collection in April 2022 and will end in June 2023. The data from this supplement will be used to inform partners around cannabis legalization during and after pregnancy, as well as perceptions among the population and population around the safety of using cannabis. This information will also be shared with CET to supplement their exposure information on marijuana. I also want to point out that the data collection in Connecticut params on cannabis won't stop in June 2023. There will also be questions in the phase 9 survey that is currently being developed on cannabis use. It might just not be this expansive as a supplement. Additionally, the PRAMS opioid supplement question on substance use has been used to evaluate Capta data in collaboration with the Capta evaluator. And this evaluation has been really informative, and manuscript detailing this evaluation is in progress. I think it's going to be submitted to a journal soon, so keep a lookout for that if you are interested in how you can use PRAMS data to evaluate Capta. Since it's a different type of data, Capta is based on screening, while in PRAMS it's based on self-report. So it was a great collaboration between two different groups, and it's great work. So I hope you all look out for it. So since collaboration is a theme throughout this presentation, I would like to wrap up this presentation with sharing collaborative work on improving respectful care in Connecticut using community-based partnerships and collaborations, and by prioritizing patients' voices. So just a little bit of background on why we decided to focus on improving respectful care in Connecticut. In 2021, Connecticut PRAMS determined that nearly 1 in 10 Connecticut mothers reported being treated unfairly and getting health-related services during pregnancy based on one or more factors, such as their race, ethnicity, or culture, age, language spoken, citizenship, insurance or Medicaid status, or some other reason. And these experiences were disproportionately higher among most racial ethnic groups of color, with the highest reports being among non-Hispanic, Black, and Hispanic birthing people. More specifically, reports were 2.4 times higher among non-Hispanic Black mothers and 2.1 times higher among Hispanic mothers compared to non-Hispanic white mothers. In response to these findings, Connecticut Department of Public Health, Connecticut March of Dimes, and Connecticut Maternal and Child Health Coalition created Connecticut's Reproductive Justice Alliance, or Alliance, in spring 2021 to address inequities in maternal and reproductive health and justice in Connecticut through multidisciplinary partnerships. The Alliance consists of 30 plus individuals who represent those with lived experiences, doulas, community-based organizations, and Connecticut state agencies and organizations. The structure of the Alliance includes a leadership team, which provides leadership and oversight and meets weekly. There's also the core team, which provides guidance and expertise and meets quarterly. And there are 2 work groups, so one on data and one on focus group discussions, which provides support and meets as needed. So the key objectives of the Alliance include increasing access to respectful quality maternity care, increasing respectful interactions between patients, providers, and staff, increasing quality healthcare systems and resources and policies related to maternal health, and increasing accountability of healthcare systems by centering patients' voices. To reach these objectives, we are currently focusing on 3 activities, but we do acknowledge that more will be needed to reach these objectives. We are, first of these activities, we are planning and conducting qualitative research, including focus group discussions. Excuse me. We're including focus group discussions with non-Hispanic, Black, and Hispanic individuals who experienced a recent childbirth. We'll use the findings to help identify interventions or activities for strategic planning and improving respectful care, as well as access to care. We are also planning on doing in-depth interviews with facility staff to help find more of these strategies and activities in improving respectful care. We are also increasing community engagement and creating new partnerships within communities with the goal of making sure community members have a voice in our activities and to have shared decision-making and research. And lastly, we are creating and sharing data products with a health equity lens to help improve data sharing and transparency with communities so people are more informed. So to achieve these objectives, the Lines is fostering new partnerships with communities most affected by adverse maternal health outcomes to better understand needs and to help identify and implement effective strategies to improve maternal health and well-being. Together, the Alliance members are prioritizing patients' voices by conducting these focus group discussions with Black and Hispanic individuals to better understand their experiences giving birth in Connecticut and to identify strategies to improve access to respectful, quality maternity care. The results of the qualitative work will be summarized and shared with partners and communities, and the results will also inform efforts on improving respectful care in Connecticut to improve quality of care and ultimately reduce disparities in maternal health. So far we have learned that ongoing input and participation from non-Hispanic, Black, and Hispanic birthing persons and CBOs have strengthened the ability of the Alliance to be responsive to communities. We have also learned that a collective approach, including non-Hispanic, Black, and Hispanic individuals, CBOs, and state-level partners, allows for incorporation of various perspectives and approaches, which is important in addressing adverse maternal health outcomes through the lens of respectful care. And we do hope that the results of this work will also help inform partners like CEPI-CT on respectful care, because that is something that is important to this initiative. I just want to wrap up with the summary slide of the key points that I want to conclude the presentation with. So first, collaborative research can help identify opportunities to prevent pregnancy-associated overdose deaths, as well as improve outcomes for substance-exposed infants. The collaborative work on pregnancy-associated overdose deaths has led to important discoveries of possible barriers to care in the postpartum period. Second, comprehensive care that include the parent or caregiver is shown to improve outcomes for infants exposed to substances in the womb prior to birth. Collaborative work on implementing Eat Sleep Console tool has supported the use of non-pharmacological steps in improving the health of babies with NOWs. And lastly, collaboration across various state and community agencies and organizations, as well as including those with lived experiences, are important for providing needed services and supports for infants and birthing persons impacted by substance use, including patients' voices, is an important step in respectful, informed, and personalized care to individuals of various backgrounds. And here is this last slide, the disclosure, and also I am leaving my state email here. If you have any specific questions, or if you, related to, Capta, Plans of Safe Care, or any of the CDC work, I can answer maybe some now, but feel free to reach out to me. So maybe I can help make connections with any specific people that might have more in-depth knowledge of whatever you are interested in. And that is it. Thank you.
Thank you very much, Dr. Baca. It's a whirlwind tour of a lot of data, so we really appreciate it. And it's nice to connect with the data with the program work. I just say from a reflection of hearing you, some of the work that you're doing in Connecticut, we've also been doing in Maine. So back in 2017, there was a group that worked with the birth hospitals with our Perinatal Quality Collaborative to get Eat Sleep Console implemented. And we worked very closely with our New England Quality Improvement Network and Dartmouth, which had been one of the original partners on the project. And so we've been doing some of that work. And you'll hear in the State of the State panel coming up in the next hour, a lot of the work that's been happening on Plan of Safe Care and the Capta reporting. So it's great to hear some of how you guys are approaching it. And I hope that the audience will stick around in the next 2 hours to hear how some of the work is happening in the state. And I also posted, there is a new website that the state epidemiologic opioid working group has posted to provide data to publicly around substance use amongst pregnant and postpartum individuals and substance exposed infants. So there's a new dashboard out that I think people will see in the live stream chat, where they have really tried to look statewide at what data exists and provide it on a public website for folks so that we can track it. And it's a working website, meaning if there's new data sources that come out, they will be doing periodic updating. So one of the questions in the chat is that sometimes there is a strong focus on women and people with substance use disorder, opioid, using opioid substances, but what about women who are using methamphetamine and cocaine, even nicotine, alcohol, other substances? How are you approaching that in Connecticut? How are you tracking it? Because polysubstance use is really what we see a lot in the hospitals. So just curious as your thoughts on that.
It's a great question. I do know that, so we do have a Capta evaluator who is looking at the Capta notifications. So she is looking at the polysubstance use, since that is a major topic of interest, as the person mentioned. I did not grab that information for the presentation, but it is something that is being looked at and it's being tracked. It is. Maybe that is something that should be added to the dashboard so it can be publicly, people can be informed on that and publicly, because I do agree with you that whenever we get more information, more data, we should be sharing this publicly. It's just so important to, share whatever information we have. So maybe that's something we can add to that dashboard, and that one figure that has those bars, since I think there is a footnote there that those that bar figure is not mutually exclusive. So that is maybe something that could be worked on.
Great. And the new dashboard that I was just talking about in the state does pull some data from the substance exposed infant notifications that go through our Capta reporting to the Office of Child and Family Services. And as part of that reporting, the state does collect that data in Maine. Usually the Office of Child and Family Services publishes an annual report with that data, but it's now being put on our state website so that if there are folks in the audience who are interested in looking, you can see some of the breakdown. But I do agree, as we're starting to, as all these programs are developing to support women and pregnant people around substance use treatment, that is something that is really being looked at, is really the polysubstance use. Sometimes when the state gets federal funding, like folks will hear about the MOMS grant and the work happening with Maine Care with a lot of substance use treatment providers, like there's specific guidelines in the federal funding that comes down, and that's why the opioid piece is really highlighted, but that doesn't mean that the polysubstance use is not being addressed in that work. So I just wanted to mention that. Another question, when this is probably more for me, when will the state begin expanded screening of patients for substance use disorder? And will this be all pregnant women on Maine Care, or who's the intended population? In fact, in the state, in terms of working with obstetric providers, a lot of the maternity obstetric providers do screen their patients for substance use disorder. The Maine MOMS program is right now focused on women enrolled in Maine Care, but the state has been working for the past 10 years to really work with maternity providers on universal screening for pregnant women. Previously, we called this the Snuggle Me Project, and some of you may have heard that term with the Maine CDC, the Maine AAP, ACOG, and maternity providers. They worked for 2 years back in 2010 to 12 to come up with some guidance around screening. That was revised in 2018. And really, we've started to transition in the state with the Maine MOM program to more of the national guidance. Early on, there wasn't a lot of national guidance, and so it was kind of developed by local experts, but now it's really, we're kind of pointing people to the national guidance. And so really, it's all women should be screened for that in pregnancy, and one of the tools that they use is called the 4Ps Plus. In terms of the Maine Care, so Maine Care has worked with a select group of providers with the Maine MOMS program, and they'll talk about this in the next hour. but they are working on policy to be able to expand that program to more obstetric and treatment providers throughout the state in the coming years. So that is on the horizon for those women enrolled in Maine Care. And in our state, about 40% of pregnancies are covered by Medicaid. I think I was going to have you just, my questions for you really is, when you're looking at all of your data in the state in Connecticut, what data causes you the most concern as you're thinking about maternal child health, and what programs you need to develop, and what provides you with the most hope? Where have you seen the most progress?
Question. So one of the statements that we say a lot for Connecticut is Connecticut has some of the best maternal and child health outcomes in the nation, but it's the equity piece, the disparities that we see that is the issue. And I think that's something we need to work on highlighting, is the disparities. And so we can further that work on reducing disparities. So that's something that, I know that's not the data piece, but data translation is so important, is like how we use our data and translate it to the public. So that's something that we are working on at DPH, is focusing more on the equity piece. And as EPIs, we're really trying to push ourselves on using the most effective way of using that health equity lens. Recently I went to the MCH Epi conference at City Match in Chicago last week. And one of the biggest themes there was misclassification of race ethnicity in data. And that was really informative. And I'm currently just going through all of those variables in my data sets to make sure that I didn't, accidentally do anything that would hide a specific group, since we want to make sure that we are representing everyone as much as possible. And it is hard when you don't have as many births as like California or Texas. I'm sure, how many births does Maine have a year?
Around 12,000.
Yeah. So, we have more than that. We have double than that. And it's hard to find ways, even combining years of data, it can be really hard. So just trying to, find ways to make sure we're not misrepresenting the data by grouping people to other, so I hope that answered the question.
Yeah.
Probably not.
Yeah, no, it's great. I think that's something that we are also focused on in the state, really developing more robust programs that include the principles of diversity, equity, inclusion, and belonging. And there is, at the Maine CDC, they have reestablished the Office of Population Health Equity, which I think we'll hear about later on in the morning, and really trying to reevaluate the programs that are offering maternal child health services, and how do we really reach diverse populations, and also in our state, how do we reach rural populations and areas where there's different socioeconomic status that may disproportionately not have healthcare. So, all of these things are really a strong focus for us in Maine. I think the last question for the morning, someone was asking about, I think Gordon Smith at the very beginning had talked about the state opioid strategic plan and prevention strategies. So I will send a link to Lorena, who will put it into the chat box. There is currently, the Maine has a strategic opioid plan that includes prevention and treatment in it, as well as leadership. And the plan was developed, it was revised about a year ago, and Gordon was talking about they're in the process of doing another relook and revision, and there is an upcoming webinar coming up where they're getting stakeholder feedback. So we'll put that information into the chat box for people to be able to both join the webinar and also review the plan. So Dr. Baca, I really want to thank you so much for all the work that you did to put together this presentation. We're glad that you've been a strong partner in Connecticut. We've really looked in Maine to our partners in New England, to both Connecticut. We talk to folks in New Hampshire, Vermont, Massachusetts pretty regularly as we put together our maternal child health programming. So we're really delighted that you could join us today to both give us the Connecticut perspective, but also the national perspective. So thank you so much, and hope you are enjoying the fall weather. And I want to thank everyone who is online with us today, and we will be turning to the State of the State panel next. So thank you very much.
Thank you. Have a good one.
Thank you very much.
Bye.
Good morning, everyone. It's so wonderful to see all your faces. My name is Maryann Harakall. I am the Maternal and Child Health Program Director for the Maine CDC. That first presentation was amazing, wasn't it? What a great way to kick us off this morning. It's going to be a great 2 days, I can tell by looking at the agenda, so get ready. So I want to today we're going to be keeping with tradition. So our state staff have prepared a set of slides to fill you all in on what we've been up to over the past year, and then also on some things that we're going to be rolling out over the next 12 months. And so one of the things I do want to highlight a little bit this year is we've added a whole bunch more partners. And this highlights the growth of the partnerships and also the importance of maternal and child health, along with our substance use disorders and the effects that it has had on our children and families in Maine. So without further ado, I'm going to let our state staff go ahead and do their presentations. And so our first presenter is Jamie Cotnoir. She is the Associate Director of the Division of Disease Prevention at the Maine CDC. So Jamie, I'm going to go ahead and let you take it away.
Wonderful. Thank you, Maryann, and thank you all for joining us today. I'm very excited to kick off what promises to be a very exciting State of the State. So the division that I oversee includes 4 programs. The first of which I'm going to speak about is the Maternal and Child Health Program. Each of the programs within our division has multiple sub-programs within it. And so within the Maternal and Child Health Program, there's a lot of stuff that they oversee, and you're probably familiar with a lot of them. So the Maternal, Fetal, and Infant Mortality Review Panel, our family planning contracts, the Maine Families Home Visiting work, our somewhat new project, the Maine Pediatric and Behavioral Health Partnership. It's in year 4, but this is still a newish opportunity that the state's been excited to oversee. Our Safe Sleep and Substance Exposed Infants work, our Early Childhood Comprehensive Systems Grant. This is another newish grant to our portfolio that we've been really excited to partner with a lot of the folks actually in this panel today to expand the work that we're doing within the early childhood systems. And then our Children with Special Healthcare Needs program, which includes a bunch of sub-programs even within that, including newborn screening, the newborn hearing screening, cleft lip and palate program, birth defects, and care coordination. So next slide, please, Maryann. The Maternal and Child Health Program, like all the programs within Maine CDC and our division, have been very busy over the last year. One of our biggest accomplishments, I would say, is Maine was one of 9 states to recently be awarded a state maternal health innovation grant. We're really excited because this will allow us to increase our capacity to more accurately and in a more timely fashion collect data and ensure that safety bundles are implemented at our birthing hospitals. We've also had staff that have been asked to present at many regional and national conferences, highlighting a lot of the work that's been happening in Maine related to maternal and child health. Cytomegalovirus legislation was passed in the last legislative session. This will require screening of babies who fail 2 hearing tests after birth for CMV, which can help prevent some lifelong health concerns moving forward. Our ECCS program has hosted 5 focus groups with parents and families to hear more about their lived experiences. And finally, on this slide, we have an advisory group, which includes state, local, and community partners that we created to help us guide our early childhood systems work. Our Safe Sleep Kit reimbursement program, which is something that we've launched somewhat recently within the last couple of years. It was added to AmChip's innovations database as an example of an evidence-informed policy implementation. So we're really excited to be a national leader and recognized for the work that we're doing, working with our birthing hospitals to provide safe sleep environments for newborns. Our pediatric mental health grant, which, as I stated earlier, is a newer grant to our portfolio. We've served 556 children and adolescents through psychiatric consultations with primary care providers to help kind of ease some of the pressure that we're seeing at psychiatric practices and helping children be served within their primary care home. And staff development was provided to over 2,000 participants on mental health topics across the state. Looking ahead to the next year, we're participating in projects such as our ECHO series for AAP innovations on newborn screening interoperability. It's a mouthful. Facilitating the Maine Parent Ambassador Program, working with Educare, and we're going to be hosting an ECHO series throughout the next year, focused on the pediatric mental health access work that we're doing. We're also going to be working with our partners across the state to improve our maternal morbidity and mortality and severe morbidity rates. So I've spoke about, we did receive one grant that was very competitive, but we've also received 2 other grants into the state in the last few months with several of our partners. So there's going to be a really big focus coming from Maine CDC looking at improving our maternal mortality and morbidity rates. And we're really excited to enhance that work. And we're going to continue to recruit birthing hospitals to participate in our AIM safety bundles. So WIC has also been busy. We have rolled out our e-farmers market nutrition program statewide. So last year we moved from paper check benefits to the e-WIC, and now we're also doing that within the farmers markets. So we're really excited that people will be able to, or have been able to, redeem their cash value benefits at markets. We're supporting our local farmers, and we're increasing access to fresh fruits and vegetables. WIC has also done a lot to enhance their technology that they're using with our participants. So we're doing two-way texting with our participants from the state agency here in Augusta. We're also working with our folks in the well water program, doing well water testing with WIC participants. And next month, our WIC office is holding a statewide conference on value enhanced nutrition assessment with the creator of the VINA program. So we're really excited for that. We've also, over the last year, embarked on increased breastfeeding support for parents. And so we started a 72-week breastfeeding support texting program. So looking at prenatal and postnatal support for folks. We've done breastfeeding peer counselor program staff training, and we've increased our funding for that. So we're really excited to enhance that piece of it. And we've also been able to provide additional breastfeeding support supplies, including nursing pads, nursing bras, breast pumps, so like hand pumps, and also electronic pumps. So really trying to help support parents, especially during the recent infant formula recall, to make sure that babies have what they need for nutrition. Moving forward, we're going to continue our work with farmers markets and enhancing our cash value benefit redemption. So people will be able to use their fruit and vegetable vouchers both at grocery stores and with WIC approved farmers, and continuing to expand the farmers that are accepting and working with WIC on our farmers market nutrition program. We're also going to continue to work on our breastfeeding curriculum, launching that, more training statewide, also working on developmental screening trainings for our WIC staff, and continuing our two-way texting with our participants. Chronic disease has, again, similar to maternal and child health, multiple programs within the larger group. I won't read all of them to you, but there is a number of new grants that we've added to our portfolio in the last year, focusing on community health worker engagement, and also our colorectal. Actually, if you want to advance, Maryann, I'm jumping ahead on myself here. We're awarded our new 5-year cooperative agreement for cancer control. So really excited to be continuing that work. We work in partnership with the Data, Vital Records, and Surveillance Office with the Maine CDC. We are finalizing our Alzheimer's and related dementia plan for publication. And as I stated, we were awarded our grant for community health worker engagement related to the COVID response, but this will really help inform our community health worker efforts across the board. And so I think that we'll see some benefit to this as well in our maternal and child health work moving forward. We're sunsetting 2 of our newer grants, the Office of Minority Health grant that we received focusing on Black or African American populations with HIV and diabetes is sunsetting, as well as our core grant that we've used recently for the Alzheimer's and related dementia work. And we're preparing for an upcoming application that will hopefully enhance and develop upon the work that we did within that Alzheimer's and related dementias work. And then moving forward, we're going to be updating our website around diabetes prevention and control, which is rethinkdiabetesmaine.org. Our asthma program is going to be launching their self-management education program, and the state plan for Alzheimer's disease and related dementias will be continuing to enhance that plan as we move forward. We kind of think of it as a living document. For our tobacco and substance use prevention work, this program includes tobacco and substance use prevention, but it also includes adolescent health and injury prevention, suicide prevention, school-based health centers, and the MIAS, or the Maine Integrated Youth Health Survey. And this program, again, a lot of work's been happening lately. So over the last year, we worked with our partners in the Office of Maine Care Services, and now we have a standing order that allows Maine Care participants to access nicotine replacement therapy directly from the Quit link without a need to visit their primary care provider. So removing that barrier and increasing people's access to nicotine replacement therapy. We've also recently secured 3 new federal grants that will bring in approximately $12.5 million over the next 5 years to increase and enhance our substance use prevention efforts, particularly with youth and young adults. We've also distributed prescription lock boxes and drug disposal pouches throughout Maine, working with our partners at Maine Mom, our partners in the local Office for Family Independence, regional offices, and other partners across the state, to help make sure that medications and other substances in the home are securely stored to prevent accidental ingestion for youth. And excitingly, last week, our Maine Integrated Youth Health Survey data is now available on our website as of last Tuesday. So we encourage you to take a look at the survey data from the last year. Moving forward, our new model for community health prevention, which we're calling our Maine Prevention Network, will be kicking off in January 2023. And that will include our obesity prevention, our substance use prevention, and our tobacco prevention work. We're expanding resources, screening tools, and nicotine replacement therapy in our OBGYN practices. So really trying to target pregnant and postpartum women, trying to help support them in quitting smoking or using nicotine products. We're updating our cannabis education toolkit now that adult use cannabis is legal in Maine, really trying to make sure that we have tools to support our community partners, parents, schools around cannabis use in Maine. We're excited to partner with the governor's office to implement a $1 million investment in substance use prevention in our middle school youth. Our state epidemiological work groups, our outcomes work group, has updated our pregnancy data dashboard, and that will be launching soon. We're really excited for that information to be available to folks. And as Gordon mentioned earlier in his welcome, we are working on increased investments in our screening, brief intervention, and referral to treatment, or SBIRT program. And we're creating a statewide implementation plan related to SBIRT. And finally, within this group, we have expanded our school-based health center footprint across the state, thanks to investments within the Department of Health and Human Services and our partners in the Department of Education. We have added new school-based health centers to our partnership, and we've enhanced the services that are available at our existing school-based health centers. So we're really excited about that opportunity as well. So accomplishments center-wide, our Office of Population Health Equity has been created and staffed, mostly full staff now at this point at the Maine CDC. We have provided COVID-19 vaccine for children throughout the last year, and we've continued to provide catch-up for routine vaccination for children of all ages, working with our public health nursing program and our partners across the state. And we have an updated dental clinics and services directory available on our website. Moving forward, we're preparing for the COVID-19 bivalent vaccine to be approved for younger children. So currently that's available for youth and adults ages 12 and up, but we're preparing for the approval for children under age 12. We're going to be offering flu vaccine clinics moving forward. The Maine legislature mandated that all schools in Maine test their drinking water for the presence of lead. And so our drinking water program is working with schools on drinking water testing throughout the summer and then moving forward. And we're going to continue to maintain and build our partnerships across the department, as well as with our partners at DOE. And that is my team. We are small but mighty, and I'm very proud of all their accomplishments over the last year. Thank you, Maryann.
Great, thank you, Jamie. So our next presenter is going to be giving some information about the maternal and child health data update. Many of you have met Ericka, but Ericka, I will let you go ahead and introduce yourself.
Thanks, Maryann. Can everyone hear me?
Yes.
Great. Hi, everyone. My name is Ericka Lichter. I'm on the faculty in public health at the University of Southern Maine, and I work as the lead maternal and child health epidemiologist at the Maine CDC. And I really appreciate having the opportunity to present on some of the data related to maternal and child health. And following some of Dr. Baca's presentation, I'll be providing you some Maine-specific data related to some of the things that she spoke about. And I'm glad that Amy put in the chat the new pregnancy and substance use dashboard, because some of the data I'll be showing today you can also find there. So we'll make sure to put that in the chat, as long as also the Maine Shared China, which also has a lot of data related to public health. Before I jump into, I just also want to acknowledge that my team of other epidemiologists at the Maine CDC, Cindy Murphy, Fleur Hopper, Andrea Lenartz, have all contributed to this presentation. So I just wanted to start also by just acknowledging that COVID has kept us all very busy over the last couple of years, and the maternal and child health epidemiologists have been tracking the impact of COVID on perinatal health on a regular basis. So we know that between March 2020 and August 2022, there were over 5,000 infants that were diagnosed with COVID who were reported to the Maine CDC, and we understand this is likely an underestimate of this. We've also linked birth certificate data to COVID-19 case data to try to ascertain the number of pregnant women who had COVID during this time. And my colleague Andrea did that, and she identified at least 880 pregnant women who were diagnosed with COVID between March and December of 2021. She also did some analyses looking to see if the COVID had any impact on birth outcomes, because nationally they have found some relationship between COVID-19 and outcomes such as prematurity and stillbirth. In Maine, we have not seen that impact, at least with the data that we have. But we have been monitoring the impact of COVID on birth outcomes throughout the pandemic. And one of the things we did note was that prenatal care was one thing that was impacted by COVID. And we saw a drop off in prenatal care, especially during 2020 and some of 2021. We have seen that this has rebounded, and we're back to almost where we were prior to the pandemic, but we haven't fully reached our 2019 levels. Another trend that we noticed that during this COVID-19 pandemic, but it was actually started beforehand, was the number and percent of births that were planned home births increased 41% between 2019 and 2021. So there were about 100 more babies in 2021 that were born at home compared to prior years. So one of the other things I just wanted to talk about, and I'm not going to go through all of these today, is around where Maine is doing well and what are some areas that we can improve. So the Federal Maternal and Child Health Bureau provides each state with annual data on our maternal and child health population, and it allows us to compare ourselves with other states. So here's where we're doing really well. Almost 90% of caregivers place their infants to sleep on their back. Maine is the second highest rate on this measure, as well as we're also doing well on prenatal care utilization. So although we had that dip in 2020, we still had the third highest rate of women receiving prenatal care in the first trimester. Our preterm birth rate in 2020 was the 8th lowest in the nation, but something to note is we still received a B- from the March of Dimes on their 2021 report card related to preterm birth. In postpartum, we had the 8th lowest rate of postpartum depression, and our adolescent birth rate also remains one of the lowest in the US. I'm not going to go through all of these. These are other indicators where there's some room for improvement, but I do want to just highlight that in 2020, our low birth weight, we ranked 17th in the country and 21st for our infant mortality rate. But Maryann, if you could just click again. There are really two areas that I think you'll hear echoed throughout this conference where we're facing some challenges, and it's around substance use during pregnancy. So in particular, our smoking rate during pregnancy is currently the 44th, we're 44th. We're almost, we're near the top in terms of how high our smoking rate is during pregnancy. And similarly, as Dr. Baca showed on her map of neonatal abstinence syndrome, we're the second highest rate of neonatal abstinence syndrome in the country as of 2019, only behind West Virginia. So although several of these perinatal health indicators are higher than we would like, a lot of the trends are suggesting that we're heading in the right direction. So one example is infant mortality. So many of you might remember that in 2013, our infant mortality rate hit 17 per 1,000, which was one of the highest in the country. We've made significant progress since that time in decreasing our infant mortality rate. And in 2021, it stood at 5.2 per 1,000, which is the lowest that Maine has seen in the past 16 years. To give you some perspectives, that's about 72. There were 62 infant deaths in 2021. So the 4 leading causes of infant death are preterm birth, SIDS and SUIDs, congenital anomalies, and other perinatal causes, which include things like maternal infection and birth asphyxia. So the majority of infants die due to causes related to being born preterm. However, we have seen a decrease in the rate of deaths caused by preterm birth. And in 2020, our SIDS-SUA rate was the lowest it has been since 2008. So this slide just shows the number of deaths each year in Maine. What you can see is that in 2020, for SIDS and SUIDs, and what you could see is that in 2020, there was a 50% decrease in the number of SIDS-SUIDs deaths following the safe sleep efforts that were initiated across the state, which included all the birthing hospitals receiving the Cribs for Kids certification. In 2021, we had 3 more SIDS-SUIDs deaths compared to 2020. And although we've seen significant improvements in infant mortality rates in recent years, as Dr. Baca mentioned in her presentation, we have to also discuss health equity and disparities in health inequities. And so some populations still have disproportionately higher infant mortality rates. So looking at data between 2017 and 2020, the infant mortality rates among those who identify as 2 or more races and those who are American Indian, Alaska Native were more than 2 times higher than the state rate. And pregnant persons who are Black also had a higher rate of infant mortality. And we are looking at, Dr. Baca talked about misclassification and looking at how people are classified based on race and ethnicity. And that is something that we're also looking at to make sure that we're accurately capturing race and ethnicity on the birth certificate. So go ahead, yeah. Looking at data by county, what you can see is infant mortality is based on, was highest in Maine's northernmost and westernmost counties. Some of these are small numbers and they may change over time, but that's currently where we're seeing some disparities. Along with infant mortality, we're also closely monitoring maternal morbidity and mortality. As Jamie mentioned, there are some new grants in the state that are focused on this initiative. So in 2020, there were 6 pregnancy-associated deaths. And pregnancy-associated deaths, just to be clear, are deaths from any cause during pregnancy or within 1 year of pregnancy. In this 5-year period between 2016 and 2020, there were 20 pregnancy-associated deaths. And you can see in this chart that 6 of them were caused by obstetric causes, and then overdoses, homicides, and suicides made up a relatively big chunk of those deaths as well. In terms of other trends related to substance use, you can see that, as I mentioned previously, although Maine is one of the highest rates of smoking during pregnancy in the US, this has been getting better, and we are decreasing those percentages. Just to kind of give you a little more background on what and around smoking during pregnancy, about 12% of pregnant people smoke cigarettes during pregnancy. And what we know is that about 23% smoked prior to pregnancy. So 41% of those who smoked before actually quit during pregnancy, and another 40% reduced the number of cigarettes that they smoked during pregnancy. And when we look at the demographics of this population, you can see that those who smoked during pregnancy were more likely to be younger. They were less likely to have a high school education, more likely to be married, and also have incomes less than $20,000. We have also been monitoring e-cigarette use using our pregnancy risk assessment monitoring survey data. And as you can see, about 2.5% of women used e-cigarettes during pregnancy, so it's lower than smoking during pregnancy, and about 8% used e-cigarettes before. So compared to the United States, Maine has a higher rate of women who used e-cigarettes before they got pregnant, and it's slightly higher, although not significant, during e-cigarette use during pregnancy. In terms of alcohol use, about 9% of pregnant people drank any alcohol during their pregnancy. Of those who drank alcohol, 73% had less than reported they had less than 1 drink a week, but 21% had between 1 to 3 drinks each week. And the demographics of those who drink alcohol during pregnancy is different than those who smoke. These tend to be pregnant people who are older, have a higher education. So it's 11% of those with more than a high school education actually drank during pregnancy. They're more likely to be married and more likely to have higher incomes. We also looked at marijuana use during pregnancy, and it's similar in terms of the prevalence as smoking and alcohol. So about 10% of pregnant people between 2016 and 2020 reported using marijuana during their pregnancy. And this demographics also were similar to those who smoke in terms of being younger, with lower educational attainment, unmarried, and lower income. Those who used marijuana after pregnancy were less likely to ever breastfeed. So you can see that here. So this is the blue bars are those who ever breastfed. And the green bars are those who, the legend, I guess, didn't show up. It's those who are still breastfeeding at the time of pregnancy. So of those who use marijuana after pregnancy, only 41% reported still breastfeeding at the time of the survey, compared to 71% who did not use marijuana after pregnancy. As noted earlier, and Dr. Baca showed a similar map, Maine is one of the highest rates of neonatal abstinence syndrome in the US, behind West Virginia. However, although we have one of the highest rates, this has been decreasing over time, along with our rate of prenatal opioid use disorder. We're also focusing a priority area for the MCH Title V program is on mental health, especially around the perinatal period. And we know that about 11% of pregnant people report symptoms of postpartum depression after they've given birth. But we also know that about 22% report that they had depression before they got pregnant, and 18% had depression during their pregnancy. Based on data from PRAMS, Black and African Americans were more likely to report postpartum depression symptoms, as well as women who are younger, had lower educational attainment, unmarried, and lower income. So you can see the correlation in the population between some of the substance use as well as some of the mental health symptoms. One of the things we've been trying to do more is look at some of the root causes of birth outcomes and pregnancy-related behavior by looking at more at social determinants of health. On the PRAM survey, there are questions around stressful life events during pregnancy. And we know that at least 70% of birthing people experience at least one of these stressful life events. And with these events fall into the categories that are shown here. So things like financial stresses, relationship stress, housing stress, health-related stress, domestic violence, and food insecurity. And the most common stressors reported by women were stressors related to health. So either they got sick or someone they knew got sick or died, and financial stress and housing stress. So we looked at these stressful life events in relation to several birth outcomes, and we found that those who experienced more stressful life events were also more likely to not have prenatal care in the first trimester or have inadequate prenatal care. They were also more likely to have a low birth weight baby and have a baby that was small for gestational age. They were also more likely to smoke during pregnancy and experience postpartum depression symptoms. Just really quickly, I know I'm over my time, so just to highlight a few more things that we are monitoring. our adolescent birth rate has continued to decline. We saw a small blip in 2020, but in 2021, it appears that we're back to heading in the right direction. One of the other things that we're keeping an eye on is our breastfeeding rates, which peaked in 2018, and we'd hope that they'd keep going up, but they've stayed relatively steady or have gone down slightly. So we're trying to encourage more breastfeeding initiation. And our prematurity rate, again, hasn't changed significantly over time, but it has been slowly creeping up since 2014. That's something we're keeping an eye on. And one other thing to note for a lot of you who are serving these populations is our enrollment in Medicaid and WIC has been going down over time. And this is something we'd like to encourage more women to be involved in these programs that can really be helpful for them and their families. So that's the end of my presentation. Thank you so much for your time.
Thank you, Ericka. That data was excellent, and it's a good level setting for the rest of our conference. So I appreciate that. So next up, we're going to have the Office of Behavioral Health present for us.
Good morning, and thank you for having me. I'm Kathryn Coutu, and I'm the SUD Division Manager and the SOTA, also known as the State Opioid Treatment Authority for the state of Maine. So the Office of Behavioral Health, next slide, sorry. We are the designated single state authority for SUD and mental health services. We house the federally designated State Opioid Treatment Authority. We support the development and the oversight of SUD and mental health services, as well as many recovery support services. We conduct program evaluations and quality assurance. We participate in policy and rulemaking, and we oversee a variety of the programs that are offered throughout our state. I won't list them all, but some of them include our naloxone distribution, our crisis initiatives, workforce development, peer services, Strengthen Me and Options program, as well as we support the DEEP, the Driver Education and Evaluation program for the state. Next slide. Some of the initiatives we've continued to support is the Strengthen Me initiative. Strengthen Me provides public education campaigns and free stress management and resiliency resources. They continue to provide accessible, no wrong door supports, stress management resources throughout the state for all Mainers experiencing the impact of COVID-19. With funding from SAMHSA, the teams are comprised of frontline workforce, wellness supports, behavioral health support lines, the NAMI teen text line, as well as community health outreach and psychosocial supports. Next slide. We continue to support the Options program. The Options program is 1 liaison for every county. The liaisons are vetted within law enforcement agencies. They co-respond with law enforcement and sometimes EMS. They also conduct post-overdose response calls, and the goal is to connect individuals to any kind of supports they need. We meet them where they're at. We provide syringe service program connections, naloxone distribution. We provide recovery center supports, MAT provider, detox, whatever it is that they need, as well as housing. Through the Options Public Health Campaign, which is also part of our Options initiative, we are working to improve the understanding of the Good Samaritan Law. We're working to invigorate the Have It On Hand campaign, education on safer drug practices, connecting people to local prevention, harm reduction, recovery, treatment, and general support services. Also, as part of the Office of Behavioral Health is the Maine Crisis System Initiatives. Essentially, it's the 98 State Planning Coalition, the Mobile Crisis Response Reform, and then 2 of our other initiatives are the Crisis Receiving and Stabilization Unit Center, and then our CCBHC programs. As you can see in this slide, it's someone to call, someone to respond, and somewhere to go. This is a cross collaboration through several offices within DHHS. Next slide. Other initiatives that we have been involved in is OBH is supporting an extended release buprenorphine pilot project within Somerset County Jail, also known as Sublocade. Thank you. The expansion of treatment and recovery courts in the state. We are also working on a contingency management pilot project to address the increase in stimulant use disorders. Currently, we have 2 providers. One is a community-based SUD provider, and the other is a certified opioid treatment program. We are supporting an MOUD mobile bridge pilot program, basically to serve as temporary services to fill the gaps when individuals are not directly connected with long-term services. And also, we've expanded our naloxone distribution campaign to reach community saturation. Through the 1115 Substance Use Disorder Care Initiative, in collaboration with OBH, OCFS, and OMS, we are conducting a pilot project to extend in-home evidence-based skill building services to parents with SUD disorders where they are at risk or the children are involved with the Child Protective Services. We're also planning an anticipated start date for January of 2023, sorry. We've also released 2 separate RFAs. One is the Capital RFA and a Catalyst RFA. The purpose of these are to support the expansion of SUD beds, residential beds throughout the state. Good. And then support the expansion of recovery community centers, the newest in Augusta and Rockland. We are also currently collaborating with providers in York, Piscataquis, and Franklin to establish centers in those counties. Also continued expansion of OTPs, also known as methadone clinics in the state. We currently have 12 in Maine, and a new site in Kennebec County is set to open in December of 2022. And that is the end of my slide, and thank you very much for having me.
Great, thank you, Kathryn. Next up, we're gonna have Bobby Johnson from the Office of Child and Family Services. Take it away, Bobby.
Thank you, Maryann. Good morning. It's great to be here and be part of this event. You can go to the next slide, Maryann. Within the Office of Child and Family, so I'm Bobby Johnson. I'm the Associate Director for Child Welfare Services, and child welfare is within the Office of Child and Family Services. We also, within OCFS, are responsible for children's development and behavioral health, prevention, and then we have an operations division that's responsible for technology and support, children's licensing, quality assurance. We're also in the process of hiring an associate director for early childhood education that would focus on the childcare and early childhood education efforts. Systems collaboration is a key part of the Office of Child and Family Services. And so we, with the family at the center of all of the work, we partner with all of these different state agencies across state and the community in order to design, support, and strengthen systems for families. And knowledge of and support for these initiatives is important to collectively move our efforts forward, not just within the state, but again, within our communities to support families. A couple of things I just wanted to highlight within our different divisions. So the Family First Prevention Services Act is something that the state has developed a plan for. And this federal law allows states to claim limited federal funding for evidence-based prevention services to prevent the need for removal of children from their home that are at risk of removal. And as part of that work, we have rolled out the Home Builders Family Preservation and Reunification Program. Offices are being trained as our sites are ready to take referrals. We've also expanded parents as teachers in 3 of the 5 sites. Those programs are taking referrals, and we're moving to statewide implementation in the coming year. In partnership with other state agencies, we've developed and launched Access Maine, and that is a tool for staff and others to locate services and supports throughout the state for Maine families. And then the second part of the Family First legislation is about improving quality access and supports for children that are placed in residential care facilities. So we're developing the service intensity assessment and the application process. We've worked with our residential care providers to build in and for them to be certified in the different components that are required. And then also building a network of aftercare support services for providers. So when children are discharged from their programs and returning back to their communities, they continue to have support. In addition, related to child abuse prevention, the office has hosted with the other state agencies bi-monthly child abuse prevention webinars focused on protective factors, the intersection of mental health, substance use prevention, and child abuse prevention. And those webinars are held the first Tuesday of every other month at 10 a.m. We've also been participating in a Prevention Mindset Institute with the Maine Children's Trust. And we have a representative of one of the prevention councils throughout our state, and also a parent with lived experience on that team. And it's a partnership that's focused on creating a system of family well-being and shared responsibility for children, families, and building community supports for them throughout our state. Within the Child Welfare Division, we had a review, an external review that was completed by Casey Family Programs and Collaborative Safety. And out of that came 7 recommendations to OCFS. And I've listed them all here, but on the next slide, I actually highlight some of the things that we've accomplished in these different areas. A lot of the recommendations, or I would say about half of the recommendations, were system recommendations and half were specific to the work of OCFS and specifically the Child Welfare Division. So on March 6th, we issued guidance to behavioral health providers regarding working together to ensure open communication, support, and positive outcomes for children and families. We have ongoing work with a stakeholder group that includes representatives from the hospitals, law enforcement, OCFS, and legal experts to identify and minimize barriers to information sharing and effective partnership when there are allegations of child abuse or neglect. We have updated our family team meeting policy and training for staff, and are working on disseminating a webinar for providers, parents, and other stakeholders so that they can understand the family team meeting process and how to most effectively engage in that process. We have funded an amendment to our cooperative agreement with the University of Southern Maine to hire 2 parents with lived experience in the child welfare system that will advise on policy development, training efforts, and implementation of an evidence-based parent mentoring program. And so we hired a mom and a dad. We wanted both of those perspectives represented in this work. And so we have hired those positions and are starting to develop their work plan. We have created an after-hours standby unit, also known as CES, Children's Emergency Services, specifically dedicated to providing staffing during off hours and to minimize the impact of after-hours coverage on our child welfare workforce. And then the last 2 recommendations were related to investigation timeframes and reducing duplication of work within the investigation process. And so we convened a work group of our staff, and through that work group, they brought forward recommendations about how to improve our practices. And we also consulted with national experts and got data from how other states are structured. And so those are being examined right now for planning and implementation purposes. Just a few data points I wanted to highlight. So in 2020, 52% of all removals in Maine had parental substance use as a risk factor. And that rate increased to 53% in 2021. But it doesn't mean, so it was a risk factor in the family. It doesn't mean that that was the reason that children were removed, or that that was the only reason that contributed to a child being removed, but it increased just slightly from 20 to 21. And then our substance exposed infants and plans of safe care. We've been working hard over the last couple of years with a lot of different stakeholders, both within state government and within our communities, to ensure that infants that are born substance exposed have a plan of safe care that's developed, So in August of 2022, we received 54 notifications of substance-exposed infants, and 93% of those infants had a plan of safe care developed. 69% of those were developed by the hospitals. 100% of the plans that were developed were provided to the child's pediatrician. In those reports, 53% of infants were exposed to cannabis only, and 41% were screened in for investigation by Child Protective Services. There's been efforts, and some of what I'm going to talk about in the next couple of slides you've heard about from others. So there's been efforts to expand substance use disorder treatment, and the Office of Child and Family Services has been part of that work. There's been $1.9 million invested to expand treatment in rural areas. There's been an increase in the Maine care rate for residential treatment by an average of 37.5% since November of 2021. We have been partnering with Maine Care on a substance use disorder 1115 waiver, which expands services for Maine Care enrolled parents with substance use disorder who are at risk of or already involved with Child Protective Services. And I just wanted to note that with this waiver, Maine is the first state in the nation to offer continued Medicaid coverage for members who might otherwise lose access to that service or to that benefit during the CPS process because their household size changes. And so they'll continue to be supported through having access to Maine Care during their rehabilitation and reunification process. And then the last one is the Maine Mom Program, which is improving care for pregnant and postpartum women with substance use disorder and their infants. And then lastly, I just wanted to highlight within our Children's Behavioral Health Division, and again, across divisions within DHHS, we've been working to have invested $230 million in the behavioral health system in state fiscal years 2022 and 2023. There's currently rate reviews going on for a lot of the services that our families access, so targeted case management, rehabilitative and community support services, behavioral health services, and we're also investing in helping to expand the availability of evidence-based services such as HCT, trauma-focused cognitive behavioral therapy. And then under Section 92, Behavioral Health Home Services includes a Children's High Fidelity Wraparound Program. So I appreciate the opportunity to be here today and to present and share this information. Thank you.
Great. Thanks, Bobby. Next up, we're going to hear from Maine's Early Intervention Program.
Thank you, Maryann. It is an honor and a pleasure to join you all here today. I am filling in for Jamie Michaud, who is our state Part C early intervention coordinator. I am a early intervention program manager, and I cover the Down East region. So I cover Hancock and Washington counties. And don't worry, I'm not going to take up any extra time. Lisa, you should have plenty of time to go. My update is fairly succinct and very brief. So I'm going to share with you a little bit of information about our early intervention program's accomplishments. So far this year and in the last fiscal financial year, I've expanded our list of established conditions that make children under age 3 automatically eligible for early intervention services. That has been including the substance exposed infants diagnosis. So the list is very extensive, and it can be found at the link that I've provided in the PowerPoint at our maine.gov website. Early intervention program is for children birth to age 3, and I just wanted to make sure that I was clear on that. We are CDS, but we also have a Part B, which is 3 to 5-year-olds. So I'm focusing primarily on the early intervention birth to 3 group. Maine's early intervention program was added to the Cradle Me request form, and were listed on the first page of the Maine's Plan of Safe Care, which you have heard about from previous presenters this morning. We've seen a significant increase in annual referrals and our child count data. We've seen an 88% increase in referrals from hospitals from fiscal financial year 20 to the fiscal financial year 21, and a 74% increase in infants and toddlers who've been determined eligible for early intervention under the established conditions of risk. So those can include SEI, FASD, an extensive number of conditions that are listed there. We've also seen a 77% increase in infants, that's the birth to one population, that are receiving early intervention services from 10/1/20 to 7/1/22. So in a 2-year period, we've really increased, and we're very proud of that fact, that we've increased the services that we're providing to those very, very young children. Upcoming projects and plans for early intervention. This is a very exciting one I want to tell you about, is the early intervention providers are being trained in the newborn behavioral observation with an emphasis on working with families that are living with substance use disorders through the Brazelton Institute. That plan is going to be to train all of our early intervention providers by the end of May of 2023. And that project is in the process of being rolled out right now. We are continuing our collaboration with Maine Department of Health and Human Services to create a referral pathway for all substance-exposed infants to the early intervention program. And very exciting, we're going to start a rebranding campaign that should be complete by the end of September of 2023. So within the next year, we will have a new logo, a new name, which will be Early Intervention for Me, and a new website. Next slide.
Great.
If you have questions, you can reach out to any of the following people. Roberta Lucas is our state director. Erin Frazier is the director of special services through the Department of Education. As I mentioned earlier, Jamie Michaud is our Part C coordinator for child development services. And of course, Ariana Whiting is our data manager. So thank you for the opportunity to share some of the updates for the early intervention program.
Great. Thank you so much for joining us. So next up, we're going to have Lisa Tuttle from Maine Care Services. I do want to put a little shameless plug in. If you guys have questions for any of our presenters, please make sure to drop them in the chat. Hopefully we'll have a few minutes when we're done here to answer some questions. So Lisa?
Thank you so much. And I am so happy to be here today with all of my incredible colleagues in the state that you've heard from. And also I caught the pre-session events and the conference and the early sessions this morning, and it's really been an amazing experience so far. So thank you so much for letting me present to you. I'm mostly, you can go to the next slide. I'm mostly going to present today on the Maine Mom program, which you've heard a little bit about so far, and then just touch on the 1115 waiver from the Office of Maine Care Services that Bobby described a little bit about. So here you've heard a lot about the reasons for why a focus on parents who are pregnant people who are diagnosed with opioid use disorder. There's just a little bit more information here. We know from previous presentations, Maine's been hit pretty hard with the epidemic, and had in 2017 had the third highest rate for opioid related diagnoses for mothers who were delivering in the hospital. 1 in 4 maternal deaths were associated with substance use in Maine between the years of 2016 and 2020. And in 2021, 6.7% of Maine's births were substance exposed. So a lot of good reasons to advance services in the delivery system. You can go on to the next slide, please. Thank you. So Maine Mom is a really exciting program for us. It's a 5-year cooperative agreement with the Office of Maine Care Services, where it's housed, and the Center for Medicare and Medicaid Innovation. The funding goes through 2024. We're a little over halfway through it right now. And these 3 goals here get at the services that mom delivers, but also the alignment with many other things that you've heard about this morning. We're key partners in the plan of safe care, and in the Cradle Me referral system, which I'll talk about a little bit more, and all the work that's going on with the substance exposed infants work and a lot of other work across the state. We really want to design, implement, and improve the Maine Care perinatal opioid use disorder treatment services, to broaden education for healthcare teams on best practices, caring for pregnant and postpartum people who are living with OUD. And then importantly, as I just said, partner and collaborate to strengthen Maine's systems of care for pregnant and postpartum individuals who are living with OUD. We have launched some media campaigns. Hopefully you've seen some of that, and we'll continue to do so as we go forward. You can go to the next slide. So Maine Mom Services, we are so happy, just as someone pointed out earlier, that the Office of Maine Care Services was able to expand postpartum coverage to 12 months. It's really, really important for this population. Mom services span prenatal and postpartum, and these are just some of the key aspects of it. We partner with the healthcare system, partners in the healthcare system. There's 19 sites across the that are delivering mom right now. And once Maine Care policy is completed and mom becomes a Maine Care service, we'll focus on expanding to more providers. The model includes group counseling and recovery coaching services, the provision of medications for opioid use disorder, screening for health-related social needs, referral to coordination with maternal, infant, medical, and other supportive services, care planning, including a lot of collaboration with the Plan of Safe Care, and advancing, importantly, conversations about contraceptive care should the participants desire to be educated on that front. We also are partnering with birthing hospitals around the Eat, Sleep, Console approach and advancing evidence-based pain management protocols. And we can pop through. So this is kind of an example of the classic mom model. There's some players in here that you would expect in the typical prenatal and postpartum care team, but we've highlighted here important additions that the model allows us to bring into the delivery system. One is the role of the patient navigator, and the other is the role of the recovery coach. And just a footnote here, the clinical delivery partners who are rolling out the mom services can configure the way that they do mom services in a few different ways. And those ways depend really on the locus of care. So that when you see they can partner with an OB clinic, depending on the model that they're implementing. I'm not going to go into that now, but there is flexibility in the model for different configurations of partnerships, but all the services must be delivered. And let's go to the next slides because they dive into the roles of these kind of new additions, which are really, really important. So the patient navigator competencies are listed here. The patient navigator is a really important role in the mom team to help engage patients into care, to help with the assessments of some of the gaps, and to work to fill those gaps within the community resources, develop key planning and linkages, and really work as an important team member within the mom sites to keep everybody updated, sharing information and partners. They do a lot of work educating mom patients and work on aligning the team for safe and seamless and efficient care. And the next slide, I believe, goes into the recovery coach competencies, which is a really just a beautiful addition to the mom team. Recovery coaches offer serious connections for pregnant people who are living with OUD. They have lived experience, they're peers to that, so they can provide support to pregnant people around real life situations. They are recovery coaches in this model are receive training and education through a standardized and accepted recovery coach curriculum. They guide and mentor others through their recovery in individualized way. You know, they can meet in the community in coffee shops or easy venues. They have a lot of flexibility in how they're able to interact with pregnant people and people who are in the postpartum period. They really encourage choice and honor multiple pathways to recovery and offer connections, essential connections to the larger recovery communities. They don't provide clinical services or medical treatment or substance use disorder. They really are there as a peer to support recovery aspects for people who are living with opioid use disorder and receiving prenatal and postpartum care. You can pop into the other slide, please. So referring to and enrolling in mom, this slide, I really wanted to highlight this relationship we have with Cradle Me. That's been referred to by my colleagues previously. Mom is an important, Cradle Me referrals are really important to mom. And we have a liaison, a community liaison who works with referrals to mom that come through Cradle Me to make sure that they're appropriate and make sure that people are connected effectively to mom's sites and can receive services. We also have a Maine Mom webpage, which is listed here first, where anyone can go and search Maine Mom sites that are closest to them and find sites that could be accessed for Maine Mom services. And the next slide just shows a year of our service delivery. As of July 22, we had 84 people engaged in the past year in mom since July 2021. 32 patients delivered a baby and 26 of those delivered while part of Maine Mom. And on average, patients have remained enrolled in Maine Mom 6 months postpartum. It's important to point out that in order to receive Maine Mom services, it's not required that there's a live birth. So mom services can continue if there wasn't a live birth involved in the pregnancy. And the next slide speaks a little bit about the other important work that the Office of Maine Care Services is doing. And this has been mentioned a little bit. Bobby had a couple of slides about this, but the 1115 waiver is really important for the care of pregnant people and early intervention in our state system. And November 17, the Centers for Medicare and Medicaid Services issued a state Medicaid director letter, which offered a new opportunity to address substance use disorders through what's known as the IMD exclusion. And the IMD exclusion is, the IMD stands for the Institution of Mental Diseases. And this is really prohibitions on the size of treatment sites. So this opportunity allowed the state to expand services, as Bobby touched on a little bit a few slides ago. The waiver is effective starting in January 21 through December 31st of 2025. And it covers services for substance use disorder as the primary reason for care. It doesn't include mental health services. And you can go on to the next slide, which is also a little bit more about the waiver. As a key component of the substance use expansions, the waiver also includes community-based pilot programs to close gaps, identified gaps in Maine's treatment, substance use disorder system of care for Maine care enrolled parents. And this includes skill development services that are available, including parenting support programs such as the attachment and biobehavioral catch-up program, which is a really beautiful early model to increase the attachment of children in families, and also visit coaching to support families with opportunity to work towards reunification in really appropriate and natural settings. So families in the visit coaching would work closely with a coach to identify needs and to develop strategies for meeting those needs. There's already pilots here from the Office of Child and Family Services and that recently received more funding. So if you have questions about Maine Mom, I am available to respond to that. I am the new Maine Mom Program Manager. I joined just a couple of months ago, so I am still ramping up, but just delighted to be part of this amazing initiative with this colleague, these incredible group of colleagues with the state. So thank you very much for letting me talk a little bit about Maine Mom.
Great. Thank you so much, Lisa. Next, we're going to hear from the Office of Family Independence.
Good morning, everyone. I am Esther Miller. I'm the Maine Care Program Manager with the Office for Family Independence. OFI manages eligibility for Maine Care. OFI also manages both eligibility and program for other programs such as SNAP, TANF, HOPE. We also house the program manager that handles the General Assistance Program, working with all of the municipalities on GA. The Maine Care Policy Team at OFI, which consists of myself and Leah Studholm, who is the Senior Maine Care Program Manager, working under our Associate Director of Policy and Programs, Liz Ray, has initiated a few changes this year in our eligibility manual, which created 2 new coverage groups and expanded postpartum coverage for women who are open on Maine Care during their pregnancy. Maine Care 300, which is the rulemaking number, has not actually been published in its adopted phase yet, but it is in effect now, and we'll look forward to that publication very soon. The rule does a few things in terms of eligibility updates and changes. We fleshed out more what the reasonable opportunity period is for non-citizens to provide verification of their non-citizen status. We did a lot of cleanup in the eligibility manual. Specific for this group, we created the unborn child option, which is an option provided through the CHIP program in Maine. CHIP is called CupCare. And the unborn child option is a federally funded program that allows women who do not have a qualifying non-citizen status, so typically undocumented women, to maintain Medicaid coverage, or CHIP coverage rather, during the duration of their pregnancy. So the eligibility requirements are much like the eligibility requirements of the standard pregnancy-related group. You have to still meet income and qualifications. You still have to be a resident of the state of Maine. But for those individuals who do not have a qualifying non-citizen status, we're able to cover their pregnancy through CHIP, which allows like the full scope of pregnancy-related services. The state legislature enacted this in state law. Again, that law has not been published yet. I believe that those publications happened towards the end of the year. They allowed a limited postpartum period for this group, which is really important. They didn't define what the limited postpartum period is. So there is a limited postpartum period for the unborn child option, but it is not the extended period of time. It's a period of time that allows for a brief coverage of services after the end of the pregnancy, and it ends after the adverse point. So adverse is the date in the month by which decisions have to be made for coverage changes to take effect the end of that month or the end of the following month. We also created the federally qualified, I'm sorry, please bear with me. I am suffering through the most horrible head cold that my children brought home. Federally non-qualified individuals who are under the age of 21 also gain coverage through this rule. Those are, again, individuals who do not have a qualifying non-citizen status and are under the age of 21 and meet other eligibility criteria. That is state-funded coverage. It's not specific to pregnancy. We would expect pregnant individuals who fall under that coverage to shift into the unborn child option. The last thing and of greatest significance to the Maine Care population that we did in this rulemaking is to extend coverage for pregnant women. So previously, we allowed up to a 60-day eligibility period for the postpartum period. And now that coverage period is a full 12 months. So a pregnant woman is going to gain coverage at the point in time when she applies and is eligible during her pregnancy, or perhaps prior to that. And she'll keep that coverage for longer than the standard 12-month eligibility period, which all other coverage groups have. So she may very well have coverage as a pregnant woman for the full 9 months of her pregnancy, and then for a full 12-month postpartum period. That's been, I think, a really great option. And in speaking with individuals at CDC who study PRAMS data, hopefully some of that PRAMS data will start to change in the coming years as a result of both the implementation of the unborn child option and the extension of postpartum coverage. This just gives a quick summary of the eligibility criteria for the federally non-qualified individuals. And then the next slide should provide a quick summary of the eligibility for the unborn child option. Certainly, this is not the full rule set, but these are the basic pared down eligibility criteria for those groups.
Great. All right, I am going to stop sharing, and if all of our presenters can turn their cameras on so everybody can see. Esther, there was a question in the chat for you. Let me see here. Do undocumented women get postpartum care as well?
So undocumented women will receive a very limited postpartum period. That's the adverse action period that I was discussing. And adverse action is related to the noticing requirements that are listed in the eligibility manual as it exists today. So if, for example, today is the 28th, if a pregnant woman gives birth today and she's open on the unborn child option, we've already passed the date of adverse action for the month of September. That woman, the hospital will notify us of the birth, and her coverage will end effective October 31st. If that child is born October 1st, then that is prior to the adverse action date for the month of October, and coverage would end October 31st rather than carrying through the month of November. And that's a standard, that's a standard across eligibility categories. The federal government does not actually allow a postpartum coverage period for the unborn child option. This group was created through a state plan amendment under our CHIP state plan, which included Dean Bugaj, who's the CHIP program manager at the Office of Maine Care Services, and Leah Stedholm, again, who's the senior Maine Care program manager at OFI. And however, the state did require that we provide some limited period. So it's that period of adverse action, and that's it, unfortunately.
Okay, great. Thank you for that. We have about a minute left. I don't see any other questions in the chat. There are a bunch of comments, so I would encourage presenters to go check those out. And I don't see anything else. So with that, I think we can end our presentation. And I think we have a recovery story next, which will be fantastic to watch. And then I believe it's lunchtime. So with that, I think we're good and we can move on to the next agenda item.
Good morning, almost afternoon. Thank you for joining us. I'm Dara Fruchter, Project Manager, Substance Exposed Infants and Maternal Use Prevention at the Maine Center for Disease Control and Prevention. Over the course of today and tomorrow, we'll be sharing 3 filmed recovery stories. We'll be closing the conference tomorrow afternoon with a live mother-daughter recovery story, which begins at 4 o'clock. This summer, I traveled with a creative team to film these stories in Kennebec County, Penobscot County, and Washington County, 3 women, all mothers living in recovery. Before we show our first of these 3 films, I want to extend my deepest thanks to each of these women. I'm very grateful for their willingness to sit in front of a camera and share personal details about life living with substance use disorder, including what active addiction looked like for each of them, painful, stigmatizing experiences and difficult barriers, and what their lives look like today. They all possess a tremendous amount of courage and determination. Thank you.
My name is Jamie Corbett, and I started my recovery journey 20 years ago, but I've been fortunate and blessed to be sober these last 15 years. When I was early on my path trying to find recovery, I was terrified to let anybody know that I had substance use disorder. And I thought that if I let anybody see what was actually happening, that I'd be putting my child at risk, right? Like they'd just come and scoop him up and take him away, and that would be the end of it. But actually, as my story unfolded, what I came to know to be absolute truth is that it is safe to ask for help. And in fact, for me, asking for help is the only reason I'm alive today. It's the only reason I have my children today. The only reason why my children can look at me with pride and respect. So I never really had the formal privilege or opportunity to engage with a peer partner or peer parent or peer mentor, other than through 12-step work in my journey. But I know with 100% certainty that if I had been given that opportunity, it would have added so much bang to my efforts. And I know that because of the feedback that the people I serve today share with me about how I'm able to speak to them and hear them in a way that not everybody doing what I do for work does. Because I've been there, right? And I've been afforded the opportunity to be involved with projects that did have a component where there was a peer mentor assigned to an individual seeking the service. And man, every single time, you see more belief, you see more trust in the process, right? And that's really, as a social worker, as a clinician, the biggest tool, the biggest, most important, valuable intervention I can ever give is to build trust. It's the most powerful clinical tool. And when you have that trust, you can give people knowledge and the knowledge of themselves. And that's when the magic happens, from my perspective. The first time that I got really unadulterated honest with the medical provider, I remember going in to the office and, they do your vitals and they bring you back to the little waiting room and it's all anxious and waiting and I'm up on the exam table and I'm literally so covered in my shame, right? I'm and I give my truth that I'm struggling with opiate use and I've been intravenously using and I can't stop. And I've been to detox and I can't get 60 days to save my soul and I'm not allowed to be there alone with my son and, all of this horrible, horrible shame and things I'd never really even said out loud before. And that doctor, he got just as low and he held my eye contact while I cried and it was hard. I'm not a big person. I'm all out of my shame already, right? But he got low and quiet and slow and he held my eyes and he said, I want to thank you for sharing with me. And I want you to know that many of my patients have had a similar experience. And some have been able to find healing. And he gave me a variety of options. And he made me a collaborator in how we would move forward and helping me to heal from this experience and this substance use disorder that I was experiencing. And he didn't know it, but he set a standard then. And at that point, if you weren't making me a part of the team, you weren't on my treatment team. And so while it was extremely shame-inducing to go in and be that like bare bones honest the first time, his ability to sit with me in that, to continue to give me eye contact, were all cues that let me know I was safe to like share myself and my truth. And so I would also say to any mom or woman or parent wanting recovery, trust in your ability to identify actual caring, because we all have that. And when you can learn to trust yourself, and it'll give you that just a little bit. And sometimes that's all it takes to be able to let it fall out. And once it does, some people can help pick it up and pick you up. But unless they know, they are just powerless. And unless you're willing to ask and accept and explore options, you kind of stay powerless too.